Hi, good morning, everyone. Welcome to Bradford Health Services' last education event for 2022. My name is Austin Carroll, and I am a territory manager here at Bradford. And I cover the West Tennessee area, so the Memphis area and parts of North Mississippi. I'll be introducing and closing the session today. I want to thank everyone who is joining us today. Bradford hosts live webinars on a quarterly basis, and we are so excited to begin working on the 2023 schedule and topics. So make sure to check out our website for any upcoming events. We'll also include a direct link in the chat box to our events page, and you can check it out and check for our other scheduled events, including our virtual family program. Before I introduce today's session, I will share some important information with you. You're viewing this in a webinar format, which means that you can see the presenters, but your video and audio are off. So please use the chat or the Q&A functions located on the bottom of your screen to ask questions regarding anything discussed or specific questions for the presenters. At the end of the presentation, we'll have a discussion where questions received will be answered at that time if the presenter has not answered them previously. Today's session is eligible for 3 continuing education contact hours. Bradford Health Services is providing continuing education contact hours at no charge to you. After the conclusion of today's presentation, you'll receive an email that will include a SurveyMonkey link to complete the course evaluation for CE credit. Any materials presented and referenced today, as well as a link to a video recording of today's presentation. The survey link will be open for 30 days from today. You must complete the evaluation in order to receive credit for your participation. Woo. Certificates will be sent via email to those who complete the evaluation within 2 weeks. Please check the email you used when registering or signing in for today's session for that information. And finally, if we experience any technical difficulties today, please stand by while we do our best to resolve them. If the webinar gets interrupted in any way, we will get logged back on as quickly as possible. Now that we have housekeeping issues out of the way, I'd like to introduce our session. We are so excited for today's session titled Perspectives in Addiction Recovery, the Family System. Our first presenter today is Lucas Hoffman. As Bradford's Family Program Coordinator, Lucas provides education and resources to patients and their families on the topic of substance use disorder. He is currently pursuing a master's in public health with a focus on deaths of despair. Our second presenter is Turner Griffin. Turner is a licensed master's level social worker and is an addiction counselor at Bradford's The Estate Inpatient Facility. Previously, Turner worked for Bradford as a program specialist at a Reprieve for Men starting in 2018. And our third presenter is Samantha Farmer. Samantha is an associate licensed counselor in our Mobile outpatient office. She's been with Bradford for over 4 years now and facilitates the outpatient virtual family support group meetings. Our presenters will tell you more about themselves and their backgrounds during their presentation. So we're so excited to help them. I hope you enjoy the presentation, and I will turn it now over to Lucas Hoffman.
Hello, everyone. I am Lucas Hoffman. As already been mentioned, I am the Family Program Coordinator, and I'll be talking to you today about family systems theory. To kind of go over let's see here, some of our objectives for this section. I'm going to do an introduction to general systems theory, kind of an overview of that, an overview of family systems theory, which includes talk of Murray-Bowens triangles, differentiation, the nuclear family emotional process, family projection process, multi-generational transmission process, and emotional cutoff. We'll also be talking about family systems theory and addiction, which will sort of be peppered throughout the entire presentation. And then we'll go over codependency as well. All right, so general systems theory was developed in the 1950s, right alongside family systems theory. And it's been applied to every area of thought and study imaginable. So economics, industry, business, biology, psychology, ecology, all of the ologies that you can think of. All right. The people that were at the foundation of developing general systems theory felt that it could be used to understand any type of system, which is why they called it general systems theory. Basically, a system is a collection of parts or elements. So bones or muscles in a body, planets, people in an organization or a family, and those parts interact with each other to produce their own pattern of behavior over time. They're self-organizing. If something outside the system bumps it or nudges it or crashes into it, the way the system responds is based on its overall structure so that it can preserve its integrity. So systems, for the most part, they cause their own behavior. They're more than the sum of their parts, and they have emergent properties that come out of the interaction of those parts with each other and stuff from outside the system. Okay, sometimes the elements of a system are systems themselves. So the Earth is a very complex system that's part of a larger system, the solar system. And systems can be biological and living or non-living, like a clock or a car. So from a systems perspective, there's no separation between systems. They are continuous. So a person is a system that's in a larger family system that's embedded in the community, that's part of a society, and so on. So if you turn it around, some systems have subsystems. If a body is a system, the organs are subsystems. If the community is a system, the family is a subsystem. And we draw boundaries and define a system based on context, right? So what is the purpose of the system? The purpose of the system is understood by its emergent properties from the behaviors that it sort of exhibits. So to kind of recap this, systems have elements, pieces and parts, bones, people, interconnections between those elements. So nerve signals in a body, emotional information in a family, and a function, right? Bodies want to survive and reproduce, and families want to care for and nurture their members, right? It's a lot easier to identify elements of a system than the interconnections. If we fail to recognize the interconnections, we might miss the real cause of the behavior of the elements in the system, which leads to like faulty predictions about outcomes of intervening in the system. It's even harder to get to the bottom of the function or the purpose of a system, right? We like to make assumptions, but what needs to happen is observation over time. We have to pull the purpose of the system out of the behaviors, not about claims made about the supposed purpose of the system. Okay, so in a family, a teenager might, scream and moan about how she wants to make decisions for herself, but her behavior is so provocative and so outrageous that it's impossible to let her do that. Right? So at some level, she's expressing a wish to remain dependent on her parents. Now, that wish might come out of the parents' deep anxieties about the idea of their daughter leaving home, even though they may express that they want to give her independence, once she starts showing that she can be responsible. So in that system, the purpose might be seen as keeping everyone safe by preventing family members from leaving. So systems are sort of self-organizing, and to an extent, they're self-repairing and resilient. So I'm a system, and if I stood up from here and banged my foot on the table in front of me and broke my toe, blood and lymph would rush in to support that break and prevent infection. And then I would heal and I would be resilient. But if a meteor comes crashing through the atmosphere and smashes me where I'm sitting, I'm probably not going to recover from that, right? So there's a limit to every system's resiliency. It will break down if there's enough stress put on it from the outside. So the subsystems within a larger system, they sometimes compete and they can pull in opposite directions from each other, or from the purpose of the larger system. Like, the holidays are here, right? And I want to eat everything. I want all the wonderful stuff. I had 3 Thanksgivings from Thursday to Saturday last week, right? But I also want to fit into my Christmas morning footed pajamas so that I can take a nice family photo with my family, right? I want to remain socially acceptable in those photos. So, my sense of being socially acceptable and being healthy pulls against and opposes my need to kind of put on as much weight as I can to survive through the winter, like instinctually, right? I need to eat, but not too much. So you can see how those two subsystems are pulling against each other. Now, sometimes those competing subsystems are detrimental or damage the larger system. So like geopolitical systems, right? Currently, we have this war going on in Ukraine where Russia has invaded, and Russia is trying to take resources from Ukraine, which has damaged the larger geopolitical system, right? We all have to pay more for gas, we're having to pay more for food, and people are getting hurt, right? So you can kind of see that being detrimental. So the larger the system is, the more subsystems there are, and there's subsystems of subsystems. And so the more complex everything gets. So due to the number of interactions between the parts, predicting a system's behavior can be very difficult, which means that intervening in the system can have unpredictable outcomes. So there's a problem in Australia, and there has been for a long time. And that problem is that they have tons of bunny rabbits eating up everything in sight. All of the native plants are getting devoured by something like 600 million bunnies. Well, someone came along and thought, you know, I've got a solution for this. I'll just release a couple of million cats to deal with these bunnies. Well, unfortunately, that plan didn't work at all. And now Australia has two problems. They still have hundreds of millions of bunnies, and now a couple of million feral cats that are also eating up everything in sight and are responsible for something like 210 million native animal deaths a year. So you can see how, if you don't take a long view, observe the behaviors over time, and really are careful about intervening, you can have unintended consequences from your interactions with a system. Okay, so the way that systems run themselves is through feedback loops. And feedback loops basically come in two flavors. You have negative and positive. Now, negative doesn't mean bad, and positive doesn't mean good. Negative feedback loops simply bring a system back into balance, what we call homeostasis. And homeostasis literally means to stand in one place. It wants to keep everything status quo and exactly the way it was. That's what a negative feedback loop does. It negates behaviors. Positive feedback loops reinforce a system's behaviors. They reinforce whatever's happening and add to it. That's why they're positive. Okay, so here's some examples. Like, usually I'm a very warm and outgoing person. So if I show up at work and I'm grumpy and I'm rushing back and forth, you know, down the halls, and one of my coworkers sees me acting out of character, and they might come and ask me what's wrong and offer to help me, you know, to help with my workload, to see what's wrong with me. And now once they do that, I'm in a good mood again, right? The system has reached homeostasis or balance. It's back to the way it was before, right? This is that negative feedback loop. It negated my bad mood, right? Which is a positive thing. So you can kind of see how that's, you know, a bit convoluted and confusing. Now, you may have worked in a toxic environment where if you showed up in a good mood, someone came and burst your bubble, right? You were out of line. And now that you're suffering along with everyone else, the system has regained balance. Now, let's say I'm in that bad mood and one of my coworkers offered me help. And instead of taking that help and feeling better, I just yelled at them and said, well, how could you possibly help me? You're a smelly, incompetent oxygen pirate, right? They're probably going to be in a bad mood. And that bad mood might cascade all around the office until everyone's in a bad mood, and customer service is mean to the people that call in. And soon nobody wants to come to our facilities anymore, and the company just folds, right? This would be a positive feedback loop. The system couldn't handle the stress of how bad my mood was, and it started a self-reinforcing cycle that used up all of the resources available until the company as a whole couldn't handle it and just sort of fell apart, right? This positive feedback loop was clearly a negative thing. It was bad, right? Now, the reverse could be that I come in and I tell my coworkers how wonderful they all are, and customer service feels appreciated, sales go through the roof. And because, well, everybody's just in such a gosh darn pleasant mood all the time, Bradford does really great, and everybody starts making more money, and we all get, you know, raises. All right, so this is a positive feedback loop, right? It added to what was going on, and it made it, you know, better as a result. When you have a positive feedback loop, systems take on more resources. All right, when you have a negative positive feedback loop, systems bleed resources out of them. Now, another feature of feedback loops, particularly positive feedback loops, is circular causality. All right, this is kind of confusing because humans like things to be nice and linear. We want things in a straight line, right? We want A to cause B and B to cause C. But with systems, often event A will influence event B, which then influences event A. Okay, so like my son, he's afraid of the dark. So putting him to bed is stressful. I got to put him to bed like 4 or 5 times. And each time I got to put him to bed, I feel more and more stressed out and anxious, and because I just want to go to sleep, right? And my son, you know, I'm telling him not to worry about monsters under his bed, but he sees I'm anxious and aggravated about getting to bed to go to sleep. So he's more afraid of going to bed, right? He feels less safe. after a time, it's hard to isolate which behavior is the problem, right? Which element of the system do we attribute the problem to, right? It's a little bit of both. But by dealing with my attitude at bedtime, because I can function at a higher level than my son, it made it a lot easier to convince my son that the sleeves of the shirts hanging in his closet were a bunch of angry elephants that were going to come stampeding through his room, right? Once a cycle is self-sustaining, any attempt to define the cause is kind of arbitrary, all right, which can lead to misattributing of causality, right, and kind of misguided interventions, because the interaction is dependent and is caused by the interlocking interactions within the rest of the system. I hope that that makes sense, right? These things become very dependent upon each other. Okay, so from a family point of view, we can look at sort of an A causes B causes C, right? So a dad could criticize a mother and say that, you know, she's a smelly, incompetent oxygen pirate, and the mother will withdraw and sort of deflate, right? And then the daughter comforts the mom, who's dependent on the daughter for her emotional support, and then that daughter will lash out against the father, who then blames the daughter's behavior on the interactions with the mother and daughter are having, right? And so she's called incompetent again, and so on and so on and so on, right? The cause isn't any single member in the family or interaction. So interventions have to be very thoughtful, because intervening with an element or interaction is going to ripple through the whole system. Okay. So that's general systems theory. And let's look at family systems theory, okay? So Dr. Murray Bowen, he's responsible for taking systems theory and then applying its principles to understanding family structures, what he called family emotional systems, and in particular, addressing pathologies that develop in the individual members in the elements. All right, so Bowen started out as a medical doctor. He served as a surgeon during World War II, and he noticed that some soldiers would come back from the war and integrate really easily in society, and then others had, you know, what we call today PTSD. Right? And so he was really interested in why there was this difference, even though a lot of these people served in the same units and went through the same things. So he became very interested in psychiatry and psychotherapy. All right, so his early work focused on mother-child dyadic relationships in families that had a schizophrenic child. Right, so he just wanted to see the interactions between the mother and the child, and he took them in as inpatients. After a time, he then extended that research to include fathers. And so he would take mother, father, child triads, triangles, and he would bring them in as inpatients. And he studied like 11 families as inpatients and 7 as outpatients for up to 3 years. It was really groundbreaking work. And what he noticed was that, you know, while traditionally psychoanalysis and psychiatry focused on the individual and the intrapsychic things that were going on within a person's mind to define pathology, that it was actually in the interactions. He felt that it was in the interactions between the elements that gave rise to pathologies. And he didn't like to call these things pathologies at all anymore. What he felt was that instead of the individual expressing symptoms of their own, they were bearing the symptoms, the dysfunctions for the whole family. The symptom bearer would become the focal point of stress and anxiety that was that the system was experiencing from outside forces that were acting on the nuclear family. It's like, okay, like this. So some of you out there probably like to run, right? Some people are really built for running, like Olympic marathon runners. They're lean, they're long, and when they run, I imagine that their bodies, they don't hurt much at all. But if I have to run, when I put my body under that sort of stress, my heart holds up fine, my lungs are fine, but I've got this really long torso and little tiny legs, and my knees will start to hurt, right? I'm heavy. So when I run, my knees bear the symptoms of the stress that I put on my body system. Okay, now there's nothing wrong with my knees. My body's just not built for that sort of long distance running, all right? The pain is a symptom. So in terms of systems theory, a symptom is an attempt by the system to send a message or solve a problem. Right? The message my knees are sending is that I'm not designed for marathon running. Right? With families, the function of the system or its purpose can be understood by carefully and strategically asking family members about how they respond to the symptoms, or by looking at the real impact of the symptoms over time. So a very dramatic symptom of dysfunction in a family might be a son's suicide attempt, right? That they're feeling a lot of guilt and shame about. But this suicide attempt could be an attempt to communicate to the family and maybe even to themselves the depth of their distress, right? As well as a recognition of distress that might be hidden in the parents' lives or in other interactions in the family. All right. Another example would be like my son's nighttime anxiety. Okay, this is sort of hypothetical, but let's say my wife gets into bed with my son to help him sleep at night, which means that I frequently have to sleep alone, which, it upsets me. I don't like that. I don't want to sleep alone. But let's say that there's a lot of quiet but intense conflict between me and my wife, right? The symptom, my son's anxiety, it serves to put distance between us and it resolves some of that ongoing tension, right? We can't argue, we can't have that tension because we're no longer close, right? It solved a problem. Now, from Bowen's perspective, this is what's happened with people that are suffering from addiction or alcoholism, right? They bear the symptoms for a dysfunctional family and they feel high levels of stress and anxiety, and they cope with this stress by using drugs and alcohol, right? As I mentioned already, homeostasis, it literally means to stand in one place. So homeostasis is a process, and it's how the system maintains stability or resists change, right? By making internal adjustments in response to changing external conditions. And that's through those feedback loops. In a family, this means that they'll often return to an established way of functioning, even if it's problematic, right? To address the problem, we have to address the system, not just the individual, right? At least that's Bowen's perspective. Because the individual that's suffering from a substance use disorder or alcoholism, by their very nature, they're not in a position and are likely to be the least capable of change, right? It's like my knees. Not a whole lot the knee can do to make itself not hurt, right? If I want them to hurt less, I could put myself on a diet, right? I could lose weight and take some of the burden off the joint. So when I do have to run, it experiences less stress and produces less pain. It's a lot easier to get on a diet than get robotic knees. But what I could also do is put the knee in a brace, right? Give it some constraints and limit its movement, which is like taking someone who has a substance use disorder and putting them in inpatient facilities, right? You teach them coping mechanisms and ways to constrain their behavior and control their impulses. And then you teach them ways to feel safe. But if we don't address the family, then the system will continue to produce the same symptoms. A famous thinker in engineering and manufacturing, Edward Deming, he pointed out that quality defects are found in processes and must be prevented, not solved. This was another systems thinker. And this can apply directly to families too, right? We can't solve the individual's problem unless we prevent the same processes that produced it in the first place from continuing to occur. Right. So in keeping with our running pain knee analogy, right, I would need to prevent the process that resulted in me needing to run in the first place from occurring. So, probably not eating a donut or a cookie every time they show up in the break room. Right. Now, let's look at what Bowen in his 8 concepts. Okay. So Bowen's theory, it's based on 8 concepts, and these all sort of interrelate and overlap. And they describe emotional functioning in an emotional system, so a family system. And those are triangles, differentiation, the nuclear family emotional process, family projection process, multi-generational transmission process, emotional cutoff, and then sibling position and the social emotional process. Now, these last 2 we're not really going to cover today. They are important, they're very interesting, but it kind of takes us a little too in depth, right? I highly recommend checking them out on your own. All right, so let's look at triangles first. So Bowen considered triangles to be the basic building block, what he called the molecule of any emotional system. And all emotional systems are just series of interrelated triangles. So therapy is focused on modifying these, right? Triangles are fairly predictable. Now, a 2-person system, what we see here, this A, B at the top with the squiggly line between it, it's unstable, all right? It can stay in harmony, it can stay stable when things are calm, but if you put stress on it, it will reach out and it will grab a 3rd person to make a triangle, all right? And of course, that person that gets pulled in and triangulated on, they're going to be parts of all kinds of other triangles, right? We talked about that mother, father, daughter example earlier. That was a triangle. So when a triangle is calm, it has 2 people that are considered insiders and 1 person that's an outsider, all right? The preferred position in that case is to be on the inside, In the state of tension or stress, then the preferred position is the outsider. Now, triangles are very fluid, right? They're moving around all the time from moment to moment. The stress is moving around, but patterns that you can watch them, they'll persist for years, and they kind of constantly show themselves. But again, they're always on the move. So when things are calm between person A and B, the outsider kind of gets agitated, and they're going to try to find a way to break into the interactions between A and B so that they can be on the inside, right? So if I get home from work and I'm having a conversation with my wife, and then my 5-year-old busts in with both of his legs stuffed into one pant leg, and he's bouncing up and down and making dolphin noises, right? He wants to be on the inside of our interactions and push one of us to the outside. So I start laughing and interacting with him, and then my wife has to wait, all right? So that kind of describes how that works. Now, again, as tension builds up in a twosome, usually one person is going to get uncomfortable, right? But as it goes, they'll both eventually start to get uncomfortable, both of the people on the inside. So let's say A and B work together and they go out to lunch, right? And they start to feel this tension, this emotional immaturity or anxiety between them. What they're going to do is they're going to triangulate on this person C down here. They're going to pull that person in, even though they're not there, and maybe they start to gossip about them. All right. And now what A has done to dispel the tension they're feeling is try to push the tension between B and C. Right now, the triangle has two very calm sides, two positive sides, and one negative side with tension in it. That's what this little squiggly line is in the picture in front of you. So A has got no tension with B, A's got no tension with C, but when they get back to the office, B and C now have tension, and C can start to feel that. And what C is going to try to do is they're going to try and push that negativity, that immaturity, that tension back between A and B. And if they can't do that, then in their interactions with C, they're going to pull in yet another person to kind of move that tension somewhere else. And that's what we see in this, it looks like a Ferris wheel over here on the right. It's a whole bunch of people interacting in an emotional system, in a family or at work, who have triangulated on a lot of other people. And what we're seeing here is that the tension will eventually sort of coalesce or concentrate between two people. All right. And one of those people will get selected as an outsider. Right? They'll get pushed out of the system. Maybe they're the black sheep or the pariah in a family, or that person at work you just can't stand and nobody likes, right? Everybody's always talking bad about them. And eventually that person, maybe they'll end up in treatment. Maybe they'll be a symptom bearer. If it's a job, they're going to get fired. But what will happen is they will get replaced by somebody else, inevitably. That those triangles will be made whole again. Okay. So let's look at nuclear family triangles. Right, so the basic building block of the family is the nuclear family, and then after that, extended family systems. So in a typical family composition, a triangle would be a mother, father, son, right? So what you got here on the left, you have mother, father, daughter on the right, and those are kind of our two primary triangles, right? All marital relationships are going to have some tension in them, right? There's always maybe some arguments, some things that aren't resolved that has to be dispelled. But then, usually you have pretty stable, positive relationships, mother, father, son, right? But that can again move around. Sometimes the son is the person who has the tension with one of the family, the parents. All right. Now let's see what happens when we stick these two triangles together. All right. So, here we have like the dreaded in-law relationship is what's sort of diagrammed on the screen here, right? So you have the father, mother, son on one side, father, mother, daughter on the other. And now the tension is between the mother and the daughter-in-law, and the relationships are positive between the son and the daughter and the woman he's married, right? Or has a relationship with. And the same thing on the other side. All right, so the more triangles there are, the more people there are, the more triangles there are. And now we're going to move that and we're going to add a third generation. All right, so now we have two grandsons down here. All right, the kids have their own kids, and this forms more primary triangles. All right, so 4 people have 4 triangles, 5 people have 9 triangles, 6 people have 15 triangles between them. So it's kind of an exponential curve. The more people you have, the more triangulating that you can do. All right, now what we're seeing here is kind of an archetypal sibling rivalry. It's Cain and Abel down at the bottom, right? They've got this tension between them. They're arguing, but they have positive relationships with their parents and their grandparents. But again, this tension can move all over the place. Now, this big diagram that we're looking at is a simplified version of what Murray Bowen called a genogram. And genograms were used to diagram all of the interactions between family members as far back as a family could remember. So as many generations back as they could. And by observing the ways that these patterns of tension moved throughout the family over time, you could get a sense of, who was going to exhibit higher levels of emotional immaturity and who was going to become more emotionally mature and individuated over time, which sort of brings us into the second concept of differentiation. All right, so differentiation is the degree to which a person has developed an internal sense of self and has emotionally matured. Right, and this lies on a spectrum or scale. At the bottom of the scale, the undifferentiated person has no separation between their emotions and their intellect. There's just this unbearable pressure of the present. All right, Bowen called this a pseudo-self and referred to this as emotional immaturity. The more pseudo-self you had, the less differentiated you were, the more emotionally immature you were, the more anxiety you felt. Right, there's just this a sense of being eternally in the moment, but uncomfortable, with no real ability to plan for the future at the bottom, right? They only have a pseudo-self. Their sense of self is borrowed from the other people around them. Okay, they take on the characteristics of other people. Bowen described highly institutionalized people as being near the bottom of the scale, like people that suffered from severe schizophrenia or lifer inmates, right? They're completely at the whim of their emotions. But as we move up the scale, the intellect starts to separate from the emotions, right? The people at the very top, they still feel, but increasingly they're aware that their feelings about things and the way that they think and the choices that they make, they don't have to be connected, right? They can separate their feelings from their beliefs and experience a sense of personal identity that's organized around a core set of principles, all right? They have a very strong sense of who they are. So at the very, very top would be like a Zen monk who can sit unmoved by what's going on around them, right? The way that a still pool reflects the clouds as they pass by overhead, right? One of the big points here, though, is that there can be fairly functional people that are lower on the differentiation scale that borrow and trade their sense of self from each other, all right? But they don't have a strong sense of who they are individually, just as a group, right? People with low levels of differentiation, they're often either very compliant and chameleon-like. They accept the status quo of a situation, or they can be extremely rebellious, right? Defined as the opposite of whatever the authority says they should be. In either case, it's this adoption of a set of beliefs or ways of being that aren't intrinsic to the person. They don't come from inside them, right? You kind of see this a lot in military movies, right? There's this leader of a troop or a platoon who has this suck up that kind of follows them around and is this perfect embodiment of the rules. And then there's the blatant rebel. He wears his uniform wrong and he's always getting in trouble. And at some point in the movie, the leader convinces the rebel to come onto his side. And now the rebel becomes the perfect embodiment of the rules and order, right? They just adopted a different version of who they should be without knowing who they really are. Kind of two sides of the same coin. Right? Now, normally people have relationships with other people that are at a similar level of differentiation, and marriages are like this too, right? Which takes us on to our next topic, which is nuclear family emotional and cutoff process. All right. So people, like I said, they typically marry at their levels of differentiation. If you have two highly differentiated people, then they're usually very goal oriented. Right? They can look out on the world. They don't require a lot of thought energy or love, what Bowen called psychic energy. They don't need that from each other. They're very individual. Now, people with lower levels of differentiation, they will what we call fuse, right? And start sharing a sense of self to the degree that they are a pseudo-self. Right? Fusion with others is defined as an excessive emotional involvement in significant relationships. So fused individuals react to relationships anxieties by attempting to adopt the values and attitudes of the other person and fulfilling their needs, fulfilling the needs of the other person at the expense of their own needs. Right? So you see this a lot when couples get together and they were Ben and Jennifer and now they're Benifer and now they're sharing a Facebook page. Right? Well, one of them was an Alabama fan and one was an Auburn fan. And now, Jennifer's wearing Alabama gear every Saturday when the game comes on, right? She doesn't even pay attention to Auburn anymore. She's completely sort of lost her sense of self into the other person, right? They've completely fused. All right. When that happens, frequently what will happen is they'll start to experience an imbalance where one of them will begin to overfunction and the other one will underfunction to compensate for that overfunctioning. All right. We call this the inadequate reciprocal function, which is a big mouthful, but you can call it just a one up, one down relationship. Now, Ben will go out and get 2 jobs and he'll work all the time, and Jennifer will stay at home, and they don't even have kids, but she becomes a stay-at-home mom for their fur babies, right? She is under functioning and Ben is over functioning as a result. Okay. Now we could throw a child into the mix. All right. And now dad, Ben, he's been over functioning. He's been drawing his sense of self from the mom, but the mom begins to, she begins to fuse with this unborn child, right? She shifts the borrowing and trading of energy to that child, right? And the child, when she's born, will do the same thing, draw her sense of self or his sense of self from the interactions with the mom. And this could be the other way around. It could be the dad too, but we'll just stick with this sort of example to make it easy. Okay. So, the child clings to the mother. If they go outside, they'll play together. And if mom tries to sneak off to do her own thing, then the child stops playing completely and just follows the mom wherever she goes, right? They have to be together, right? And the child doesn't try to explore their world. They're not very goal oriented because they don't have that sense of self. It's very much tied to the mother. Meanwhile, Ben, the dad, who previously drew his emotional needs and his psychic energy, his sense of self from Jennifer, is getting cut off, right? He can't get that anymore because she's so involved with the child. And so he has to get his energy from somewhere. So he may throw himself further into work and to find himself by his job, or maybe have an extramarital affair, right? To get that energy. Now, again, the child, they don't have this sense of self, but they do eventually want to start to become differentiated, right? They want to be themselves, and what they'll go through is the process of emotional cutoff, right? As the child grows, the only way for them to get out of that bound up relationship with their parent is to tear themselves away, right? To create conflict and cut themselves off from the relationship. All right, this is emotional cutoff. All right. And it's the term giving to the tendency to manage relationship anxiety by maintaining a physical or emotional distance. All right. It's characterized by rejection of emotional attachments to family or romantic partners, and by an exaggerated exhibition of independence that creates the illusion of emotional separation. All right. Cutoff does not remove the child from the emotional system. It just distances them from it. Right? The system's still intact, but the cutoff individual now feels a sense of relief because of the space that they've put between them and the rest of the system. All right. They can do it physically by distancing themselves and having fewer interactions, or they can do it by becoming emotionally cut off so that they can remain physically close. Right. But when they're with their parents, they'll frequently start to feel like they're being almost infantilized. Right. They have to take on or act in a certain way to fit into that emotional system. Now, one of the other children, let's say there's another child that wasn't selected for this fusion process, they may actually function at a higher level emotionally than their parents, right? Because they were their needs were provided for and they were allowed to explore their world. They didn't have that fusion, right? So they may actually function at a higher level. Now, after someone experiences emotional cutoff, right, they're going to fuse with someone who's at a similar degree of differentiation, right? And they're probably a little less differentiated than their family, their parents were, all right? So they get more of this, pseudo-self mix, and that imbalance in functioning again starts to occur, right? Now, couples will deal with this emotional immaturity in one of 3 ways. And again, this exists on a spectrum. So, there's people that are pretty high functioning, but still have some fusion. And there's people that are very, very fused, like Ben and Jennifer, like we were talking about. Okay. So to deal with this fusion and maintain some sense of self, partners will seek distance. Now, one of the ways that they do this is through conflict. Now, some highly differentiated people, they'll have conflict in the relationship, and that will completely dispel the anxiety or the emotional tension. But when fairly undifferentiated couples become very bound up, they will argue to get distance and then make up so they can feel like a sense of self again once they get too far out. All right. Now, the second way that they'll do this is that they'll dispel this energy, this anxiety, is through illness. All right. through physical illness. Someone in the family, a child may develop asthma, which then becomes the focus, which makes the anxiety go away, or one of the parents may have an ulcer or develop a chronic disease, and that then becomes the focus of this this anxiety, this tension. Emotionally, this can be almost anything that you could pull out of the DSM, right? So anything from mild depression to extreme psychosis. All right. And then finally, socially. So substance use disorders, a delinquent child who's constantly out of school, and then failure to launch. Right. So failure to launch, like if you guys have ever seen that movie Step Brothers, you have two children who completely failed to launch, who became the focus of all of the tension in the family. All right. And the final way that they deal with that is through projection. All right, which brings us into the family projection process and multi-generational transmission. All right. So all families, to some degree, project the problems from one generation onto the next. If it's a high functioning family, maybe 90% of the immaturity can be absorbed in marital conflict, and only 10% of that spills over somewhere else, right? But as we get lower down the differentiation scale, more and more tension spills out into the next generation. And sometimes the parents, can appear completely functional, but have a severely pathologically non-functioning child, right? Now, the more that a family has a mix of those three ways we were talking about dealing with that immaturity, the better generally that they can share that around. Now, the degree of projection, it's usually strongest in the eldest child, but it can move around, right? So the anxiety from the spouses, again, it overflows, and people become dysfunctional over time. So projection doesn't always happen. If there is illness in a spouse that's severe enough, then that projection won't necessarily spill over. The children will remain pretty well functioning. And again, in families where there's multiple children, the ones not selected for projection, they can be very high functioning. All right. So resistance and change. The degree to which a family is undifferentiated, the more undifferentiated that they are, the more the whole family will fuse together emotionally, right? When they're highly fused, highly undifferentiated, Bowen called this an undifferentiated family ego mass. All right. And maybe you remember that movie, Billy Madison, and there was this family called the O'Doyles that were riding around in this station wagon. O'Doyle rules, O'Doyle rules. Okay. That was this family ego mass. They were defining themselves by who the family was. All right. Now, if one of those members decides that they want to become more differentiated, more of an individual, they go to therapy to try to break out of that ego mass. If they can maintain their individuality, and the growing individuality, that will spread through the whole system. So if it's a father, the mother will start to become more individual and higher functioning, and so will the children. All right. But there are three predictable steps that any system will go through to sort of keep someone from becoming more undifferentiated, to draw that person back in. All right. And those are, they'll have a negative reaction. They'll say, hey, you shouldn't be doing that. I don't see the point of why you're in therapy. There'll be a demand to change back. Like, well, you're not one of us anymore, and you need to be who you were before. And then there'll be a leveling of consequences. If you don't change, then you can't be here. You can't be one of the family. Now, if the individuating member can maintain closeness, can stay emotionally connected and physically close and keep their cool, right? And as they grow, then the entire family will start to function better as a process, as a result of that process. Okay, so family systems theory and addiction, right? We've kind of already talked a little bit about this. Problematic patterns of alcohol and substance use, they can be viewed as symptoms that arise from high levels of anxiety, which perpetuates even more anxiety in a positive feedback loop, right? The more anxious the family gets, the greater the alcohol and drug use of the symptom bearer, the more anxiety in the rest of the family, the more they keep doing the same thing that they're already doing, which results in more drug and alcohol use. Okay, so there's kind of two clinical profiles that Murray Bowen put forth, and they exist on a spectrum. So at one extreme, there's this child who has a high level of emotional attachment and fusion with his family of origin that acts super independent and says, back off, I can do it on my own. They might be extremely high functioning. They might be very successful at work and take on this disproportionate amount of responsibility within the family, over functioning while their spouse under functions. And that spouse has effectively no self, like Jennifer in our example. Then he gets caught up in unrealistic expectations from his nuclear family. So he works harder and harder, which is reinforced by greater and greater expectations as he becomes emotionally isolated. And then in turn starts using drugs or alcohol to escape from the pain that he's feeling like he has this weight of the world on his shoulders, right? And he can't live up to those expectations. At the other extreme, there's the child who's deeply emotionally fused, again, and says, I can do it on my own, but they deny their need for emotional closeness with the family of origin and become social outcasts as a result of their denial, because they don't want to be part of any other emotional system either. And they treat that isolation, again, with drugs or alcohol. So most people are going to fall somewhere between these two extremes, but it's the first profile, the over-functioning person, that's most likely going to have good outcomes from therapy. It's easier to address the over-functioner, which we mentioned earlier. So Bowen's approach to reducing the symptoms of anxiety in a family would look something like this. Reduce anxiety in the non-drinking members of the family. And this could be accomplished with some interventions from like dialectical behavioral therapy that are tailored to individual and family sessions. You could use mindfulness, staying in the, teaching people to stay in the present moment instead of ruminating on the past or the future. Increasing distress tolerance, so that we can manage emotions in difficult or stressful situations without engaging in behaviors that increase systematic anxiety. All right. Interpersonal effectiveness, which is, learning how to ask for what you want and need in a very healthy way, and learning to set boundaries, which we'll talk about later, Samantha will cover. And then finally, emotional regulation. People have to learn to watch their reactions to things that are happening outside of them, and then making choices to respond instead of react to how they feel, right? So that's separating their emotions from their intellect, all right? And so all of these kind of work to increase that individuation. Then we have to reduce overfunctioning at one end of the spectrum in the substance user, or overfunctioning of family members, the other end. Again, mindfulness-based interventions would work really well here. They're helpful so that people can watch those compulsive desires to do more than they have to, which we're going to talk about with codependency in a moment, and to interrupt the behaviors that produce the positive feedback loops that result in addiction, okay? And then this clearly define the emotional interdependence of various family members from the outset of treatment, okay? And that is that genogram that we're talking about, which is, we're going to extend that diagram as far as we can, trace back family patterns as far as we can, investigate, and then look at how those patterns evolved over time, okay? So on the other side of the coin from substance use disorders and alcoholism would be codependency. Okay, Melody Beatty, in her book Codependent No More, defined codependency as one who has let another person's behavior affect him or her, and who is obsessed with controlling that person's behavior. All right, codependency could be described as a form of like pathological complementarity, or a form of interlocking pathology. Right, it's been defined as a pattern of relation to others characterized by an extreme focus outside the self, a lack of open expression of feelings, and attempts to derive a sense of purpose through relationships, which is what highly undifferentiated people do, right? They draw that sense of self out of their relationships. Another way to put it very simply would be relationship addiction. So all of these definitions, they're very clearly spelled out in family systems theory and the literature. It kind of supports the idea that people who exhibit these behaviors, they have very undifferentiated interpersonal styles with high levels of emotional reactivity, cutoff, and fusion. And those are being used to regulate, emotional closeness and distance in order kind of to secure that sense of self and to feel a sense of security, right? So to counteract perceived threats to security, right? To keep people from abandoning them. And what this is a one up, one down, over adequate, inadequate functioning, where the codependent person is over functioning to care for the substance user, all right, who's under functioning, right? So let's look at this. Let's look at some codependent behaviors. All right, so codependency, it can be compulsive caretaking. They try to care for a person who's having trouble, but it becomes compulsive and defeating. Codependents, they often take on this martyr's role. They become benefactors to the individual in need. So a spouse may cover for an alcoholic partner, call in to work for them. A mother may excuses for a truant child, or a father may pull strings, right, to keep the child from suffering the consequences of their behavior. Right. The problem is that these repeated rescue attempts allow the needy person to continue their destructive course, right, and to become even more dependent on the unhealthy caretaking of the benefactor. So as this reliance increases, the codependent develops a sense of reward and satisfaction from being needed. When the caretaking becomes compulsive, the codependent feels choiceless and helpless in the relationship, but they're unable to break away from the cycle of behavior that caused it. All right, they're addicted to doing that. Right, these people that are codependents, they often have this exaggerated sense of responsibility for the actions of others. They have a tendency to confuse love and pity with the tendency to love people that they could pity and rescue. Right, they're always looking for their next project or people that they can fix. You might think things like, oh, well, they're doing pretty good, but if I got my hands on them, maybe doing even better. Right, they have a tendency to do more than their fair share all the time, a tendency to become hurt when people don't recognize their efforts, and they have an unhealthy dependence, as we've already mentioned, on relationships. Right, they'll do anything to hold on to a relationship to avoid feeling abandoned, even if that is to the detriment of the other person. Right, they have an extreme need for approval and recognition and a sense of guilt when asserting themselves. Right, they have a hard time asking for what they want and need. So they have this lack of trust in themselves and others. They've been lying a lot. They have this compelling need to control others. It's very human to want to control people with substance use disorders because we want to feel in control. We want to feel safe, right? And this might lead to a tendency to over control when the actions of another person make you feel unsafe, right? Again, we already mentioned they fear being abandoned or alone. And then they start to have difficulty identifying their feelings, right? Family members of people with substance use disorders, they have conflicting feelings and they can't reconcile them. They might feel love and hate at the same time. So when these two opposing emotions are pulling a person in two different directions, it may be difficult to define how they're feeling, right? They have rigidity or difficulty adjusting to change. Right, they want things to stay the same. They keep bringing things back into homeostasis. All right, and they have problems with intimacy or boundaries. Right, not necessarily sexual intimacy, but the kind of intimacy that's defined as communicating about things that are deep or meaningful and personal and demonstrate trust. Right, through being vulnerable. They often have chronic anger, which presents as a cover for the emotions that they have, which they have difficulty identifying. And then frequently, they lie or dishonest a lot. And sometimes they lie for their loved ones. They cover up and mask the truth of relationships with likely the best intentions, right? Each time someone engages in lying or dishonesty, though, to help their loved one, they begin to undermine their integrity even more. Right, their moral fiber or their belief systems can erode their self-esteem, lack of those belief systems, and so they lose trust in themselves and they start to feel shame. Right, they're often poor communicators. They believe that other people should know how they feel without expressing it, or how certain circumstances or situations should make them feel, as well as knowing what the codependent wants and needs. Without expressing themselves explicitly. And then they have difficulty making decisions. They make decisions not based on what they want or need, but on what they think others will want, right? Codependents will try to control the way that people think about them through people pleasing and trying to appease their fear of abandonment. All right, so you can help without enabling. Enabling is doing for someone what they could do for themselves, or softening the consequences of poor decisions. right? Whereas helping is doing for someone what they cannot do for themselves and allowing them to experience the consequences of their poor decisions, right? You can see the difference there. So enabling relates to behaviors. So an enabler can change their behavior with support and practice, but codependency is a state of being, right? Just like with someone with a substance use disorder, they're going to have a hard time changing these behaviors on their own, right? They need a behavioral change program. They need treatment of some kind, right? And there are 12-step programs like Codependence Anonymous that can help with that sort of thing. Finally, for this section, some considerations. As therapists, as clinicians, you have to draw a distinction between normal nurturance and codependency. There is this trend right now of people just self-labeling as codependent when maybe they are just doing normally nurturing things, helping a child that needs help, caring for children in a very compassionate way. That's not necessarily codependency, right? And so Bowen would recommend focusing treatment on the overachiever, right? On the overfunctioner. In this case, in this complementary, pathology, this interlocking pathology, the overfunctioner is the codependent, all right? So intervening there may actually be somewhat difficult because by their very nature, they are resistant to change. All right. Again, I'm Lucas Hoffman. Thank you so much for listening to my part of this presentation. And I'm going to go ahead and pass this on over to Turner. All right. Thank you very much. One moment while I struggle with my technology.
Thank you, Lucas. And I'm going to pull my slides up here. I want to say to everyone that I've been reading the chats and feel like I've been able to get to know everyone a little bit. I want to give a special shout out to the person that said Zoom had kicked them out, but they were back by popular demand. Really liked that. So I am, hold on one second here. Get to my slides. My name is Turner Griffin, and as was mentioned in the beginning, I'm an addiction counselor at the Estate in Lucedale, Mississippi. It's a Bradford inpatient facility. So I facilitate groups and individual sessions with our patients. I also work with the families, conduct family sessions, and work with the families as they're navigating the treatment process in an inpatient setting. I previously worked at a Reprieve for Men, which is also a Bradford facility in Opelika, Alabama. And it was a year-long program. And so it gave me the opportunity to really work with families for extended periods of time, longer than just a 30-day inpatient setting. I was able to work with families and help them navigate the treatment process for, the program was a year long and it's broken into phases. And so I had extended contact with these families and also worked with facilitating the family program with the Reprieve and facilitating family sessions at the Reprieve as well. So that's given me a lot of experience with working with families. And I also am in recovery myself. So I have experienced this from both sides. I myself had dysfunction in my own family due to my substance use disorder and have seen what healing can be done through the process of treatment and recovery. And it's something that I'm passionate about because of not only my work in the field and my time spent with the families that I get to work with and the patients, but also my own personal family and personal life as well. And what I'm going to be talking to you guys about is going to be family dynamics from the patient perspective. A lot of the times when, during family programming and all of that, things are geared towards the family and addressing the system as a whole, as Lucas so beautifully just went through and described the different systems theories. What I'm going to do is give you guys a picture of what the patient's perspective is in the family dynamics. So I want to look at how does the person with substance use disorder view their role in the family system. Also want to provide some insight into the patient perspective in relation to family dynamics during active substance use, the intervention process, and treatment and early recovery. The experiences are very different dependent upon where in the process that the patient is. Someone in active substance use or in the intervention process and in treatment is experiencing different levels of interaction with the family dynamics and the family systems. Also want to provide some information on approaching family dynamics with the patient in a way that fosters therapeutic rapport and motivation for recovery. I think it goes without saying, and for all of our clinicians that work in addiction treatment here on this call this morning, this is usually a touchy subject for the patient, surely for the family as well. So I want to talk a little bit about what I have found to be helpful in how to approach family dynamics with the patients as they're navigating early recovery and entering treatment and even the intervention process as well. So I want to start by opening up and looking at what the patient with the person with substance use disorder is bringing into their interactions with the family system. So I want to give some background on what the patient is experiencing on an internal as well as external level that they are bringing into the system that is informing their experience. This is a paragraph taken from the Alcoholics Anonymous text referred to as the Big Book. It's one of the first things that a patient is going to encounter when entering treatment a lot of times. And it says, men and women drink essentially because they like the effect produced by alcohol. The sensation is so elusive that while they admit it is injurious, they cannot, after a time, differentiate the true from the false. To them, their alcoholic life seems the only normal one. They are restless, irritable, and discontented unless they can again experience the sense of ease and comfort which comes at once by taking a few drinks. And so a couple of things that I want to hone in on here is after a time being unable to differentiate the true from the false as far as the alcoholic life, the using life of a person with substance use disorder becomes the only life that they can imagine. It becomes, the substance use becomes something that is required for functioning in the world. And the reason that is the sense of ease and comfort which comes at once by taking a few drinks, that when removed from the substance, the internal experience, as it describes here, is restlessness, irritability, and discontentedness. I think back on my own experience and just absolutely feeling like I, was about to jump out of my own skin if I could not obtain my drug of choice and use. And so this experience creates a normalization for the patient of their substance use, which obviously, when looking at family dynamics and interacting with the family is not going to share the same normalization of the substance use if they are not substance users themselves. If they do not suffer with the disorder themselves, they are not going to perceive this in the same way. So restless, irritable, and discontent, obviously it's a good way to describe it, but for those of us that work in this field, we know that sells it short a little bit. Addiction is a much more complicated disorder, substance use disorder, is much more complex than simply restlessness, irritability, and discontentedness. So I want to jump into that a little bit deeper so that we can have a better understanding of what the patient is going through as they are interacting in their family system. So another paragraph from the text of Alcoholics Anonymous goes into some more depth with the internal and emotional experience that the patient is going through. It says, we were having trouble with personal relationships. We couldn't control our emotional natures. We were prey to misery and depression. We couldn't make a living. We had a feeling of uselessness. We were full of fear. We were unhappy. We couldn't seem to be of real help to other people. So this is giving us a deeper look at exactly what the patient perspective is when they're dealing with their families and interacting with their families or coming into treatment, especially if they are, unable to currently use the, experience becomes misery and depression. It's feelings of uselessness, fear, anxiety, problems with self-worth, feelings of general unhappiness. And so as this becomes the norm for someone with substance use disorder, obviously they're transferring these emotions into the family system, right? It's like Lucas was talking about. This is an experience that is then transferred and communicated within that system. And what I've found oftentimes is, and I use this paragraph when working with families or doing family program, is to take this paragraph that is written in the text that is supposed to be used by the person with substance use disorder in order to aid them in their recovery and to give them an understanding of what's going on with them, and apply it to the family and see, okay, is the family suffering with misery and depression? Is the family full of fear? Is the family experiencing unhappiness? The feeling of uselessness usually comes in. I hear families feel just absolutely powerless, wanting to be able to help their loved one and feeling like they're unable to do that. And so the families that I work with that experience the highest degrees of codependency that Lucas was talking about the most, they experience these emotional issues just as much as the patient is, right? And so it becomes that feedback loop, and it chicken or the egg on who, where it started first. But the reality is that this becomes the milieu of the family interaction, and it becomes an unhealthy it forms unhealthy communication patterns. It creates toxic environments that then further worsen the symptoms of emotional distress that then require substance use in order to treat. That another statement that I say frequently that gets some blowback from time to time because it sounds counterintuitive, but I believe that it's true, is that drugs and alcohol are not the problem with the patient when they are first coming into treatment. Drugs and alcohol are the solution for that patient. Now, it's a self-destructive, a maladaptive coping skill, an unhealthy way of dealing with the problem, however you want to phrase it. But the substance use is what the patient is turning to in order to alleviate the symptoms that are described in this paragraph, to alleviate feelings of fear, depression, unhappiness, anxiety, that feeling that, I just can't catch my breath. I feel like I'm about to jump out of my skin. I'm uncomfortable with myself. And so the substance use becomes the coping mechanism in order to provide relief from those experiences. And so the underlying problem is the emotional issues, the issues within the systems, the issues within the environments that are leading to the internal state that the patient then turns to substance use in order to alleviate. So drugs and alcohol being the solution, the internal issues being the problem. We want to develop new more healthy alternatives to dealing with the internal condition when substances are removed. So again, just want to take this again and say we've dived into it a little bit deeper, but obviously this is more complex. Substance use disorder is more complex than just these two paragraphs out of the AA book as well. We also want to, consider that many patients that present with substance use disorder are also dealing with co-occurring mental disorders. So 7.7 million adults have co-occurring mental and substance use disorders in the United States. It doesn't mean that one caused the other, and it can be difficult to determine which came first. I want to get into that debate at all, but the prevalence is there. Of the 20.3 million adults with substance use disorders, 37.9% also have a co-occurring mental illness. And so not only are we dealing with the emotional issues discussed in the book of Alcoholics Anonymous, that the patient is turning to drugs and alcohol in order to alleviate, we also have to consider mental illness and mental disorders, and the reality that self-medication becomes a form of being maladaptive form of trying to treat that mental illness. So, patients who are suffering with depression disorders, anxiety disorders, PTSD, bipolar, personality disorders, obsessive compulsive disorders, substance use mixes with these disorders, and when they're co-occurring, oftentimes patients are using their drug of choice in order to alleviate the symptoms of the mental disorder that they are diagnosed with. And so it's alleviation of emotional distress. And so this, further gives us a look into, the patient is going to want to protect their substance use. Obviously, when you're looking at a situation where, maybe it's symptoms of anxiety, of social anxiety, and being around people causing immense emotional distress, it is always going to be, the case that no one wants to be experiencing that. No human being wants to be walking around feeling like they're about to jump out of their own skin. And so the substance use alleviating those symptoms creates an obsession to continue repeating that behavior. It incentivizes the behavior because of the alleviation of the disordered symptoms that the patient is experiencing. And this is something that goes all the way back to that first paragraph that we discussed, and that it contributes to that loss of the ability to differentiate the true from the false. It creates that normalization of the substance use and all the behaviors associated with it. And so as the patient is interacting with their families, this is what is informing that attachment to the substance use, and the behavior that can be seen, that, no matter mounting consequences, family problems, legal problems, social problems, problems with friends, financial problems, problems with the job, significant relationships, whatever the patient is experiencing consequentially from their addiction, it becomes normalized despite the fact that all of these consequences are occurring. And so while the family and I'm going to get into this a little bit more, the family sees that, okay, this something is terribly wrong. This is, a red lights flashing situation. The patient is experiencing it as normal. It becomes, this is how I function. This is how I function in the world. This is how I deal with the distressing symptoms that I'm experiencing when I am not using. And so want to factor in the mental illness into what the patient is bringing into their family interactions and the communications that they are having with their family. And another good way to look at this is to consider our assessments of patients when they present for treatment. So for all of the clinicians on the call today, simply think about your assessments with your patients when they come into treatment or when you're seeing them in your private practice. Think about the complexity of issues that these patients do present with. One example would be adverse childhood experiences. The one that comes to mind that I don't believe gets discussed enough, that I see a ton of, is people growing up in homes where substance use was prevalent and could still be prevalent. And so considering that the patient may have grown up in an environment where substance use was frequent and there were traumatic experiences centered around that substance use and related to the family's behavior, is something to consider when assessing a family system. What the current functioning of the family system is like, if there is current substance use, current mental illness within the family, and how is these current issues impacting the patient as they interact with their family. Look at childhood trauma in adulthood. These are, again, symptoms or events that create symptoms that cause emotional distress, which substance use is then used as a coping skill for, or a coping mechanism. We won't call it a skill. These are, I think about our veterans, someone who has experienced trauma as a result of military service and maybe experiencing nightmares, flashbacks, and rely on drugs and alcohol in order to provide them with some relief from those symptoms. It's going to, obviously further entrench that patient in their substance use. Looking at things like sexual abuse, physical abuse, whether that's in childhood or later on in adulthood. These are, scenarios that are frequently seen with patients that present with substance use disorder. And it would be neglectful as clinicians, in my opinion, for us to not consider that these issues are impacting the patients and contributing to their substance use. So addressing these issues with the patients and looking at, is any of this coming from within the family system, becomes imperative, because we need to be looking at the patient on a holistic level. And it's not uncommon for, any of these scenarios to be coming from the family system itself. And so addressing, hey, and making aftercare plans and things like that. Maybe this individual needs sober living. Maybe this individual needs long-term treatment. Maybe this individual needs to look at a relocation, away from a family system that is negatively impacting their ability to remain abstinent from substances, at least for a period of time, to give them enough space to build their foundation in recovery. This is obviously not always the case, but as we're doing our assessments, I believe that it's important that we that we look at these issues to, see what type of recommendations need to be made. And then, clearly, if, a patient is dealing with any of the things that we've discussed here, or it could be connected to just general issues with self-worth and self-esteem, and relying on substance use to provide a sense of confidence, of being able to speak with others, of being able to interact with others, to perform on the job, or whatever it is. Substance use can be used to, provide a false sense of confidence as well. And so as we're doing our assessments, we want to look at, okay, what's going on in the family system? Are there any adverse childhood experiences, trauma, sexual abuse going on? And if it's within the family system, making a game plan for how to address that with the patient as they provide us with the information, and looking at our aftercare as, okay, how do we, inform our aftercare planning based off of what's going on in the environment that the patient is in? Or if these issues are happening outside of the family system, at least having the understanding that, hey, this individual is experiencing symptomology that's coming from a complex number of factors, emotional and mental, that is most of the time negatively impacting their family system interactions. And finally, I'm not going to get into much depth on the neurochemistry of addiction. This could be a whole talk within itself, but before I transition into the intervention phases, the substance use phases, and early treatment and early recovery phases, just to kind of wrap up our background here, I want to talk about the neurochemistry of addiction briefly. So addiction hijacks the brain's reward system by producing such large amounts of dopamine that the drive for substance use can override the drive for basic needs such as nourishment, shelter, safety, reproduction, and family connection. So to give a very, very brief description of this, the neuropathway system in someone with substance use disorder becomes dysregulated, and the neuropathway system is where chemicals such as dopamine, serotonin, oxytocin, where these chemicals get moved to the receptors where they can be felt and experienced by an individual. All of these chemicals are our pleasure chemicals, right? It's where we get a sense of reward, of fulfillment, of enjoyment. And so someone with substance use disorder is experiencing a dysregulation in these neuropathways because of the spikes in dopamine that they're receiving from their drug of choice. Now, what this ends up creating is a situation where the patient is not experiencing pleasure, contentment, and fulfillment from normal everyday things that someone without substance use disorder is able to experience. Things like, hugging a family member, spending quality time with family, jobs, school, whatever it is, athletic involvement, recreation. Because of this dysregulation in neurochemistry, the only way the patient is experiencing any sense of well-being, pleasure, fulfillment is from their substance use. The example that I think of the most from my own experience is I went, on a trip with my family when I was in active addiction, and we went to see the Grand Canyon. And we were there, and I thought that I had, taken enough substances with me to keep me set through the trip. And by day 2, I'd run through all of it. And so I was out of my drug of choice, and we were supposed to go see the Grand Canyon that day. And I remember, being in the car and automatically back to, restless, irritable, and discontent, back to that feeling that I was going to jump out of my own skin. And as we're walking up, to the Grand Canyon, I just remember sitting there and looking at, one of the seven wonders in the world. It's supposed to be one of the most beautiful things that you can see. And looking at my family and being absolutely miserable, unable to enjoy a second of it. And I obviously transferred this into my family system during this experience, during the entire day. Incredibly difficult to deal with, incredibly negative and pessimistic, and angry, and saying things that I didn't really mean, and ruined the experience for my entire family. And I look back at that, and I'm able in retrospect to realize that I was unable to experience that time with my family and seeing that sight and enjoy it because of what substance use disorder had done to me on a neurochemical level, on an emotional and mental level. And the beautiful thing is that today, in recovery, I'm able to spend quality time with my family, and go out and do things with them, and actually be able to enjoy it. And I've seen that happen with so many families working in the field, and hopelessness, and feeling like our son or our daughter is gone, and we'll never get them back, and the patient wanting nothing to do with the family, the last thing on their mind being spending quality time with their family. And then to be able to see the process of recovery take place and healing take place, and families reunited, and those systems beginning to respond more positively, and each component responding more positively. It is incredible what, if you change that communication and change that energy within the system, how the situation can be altered for a family for the positive. And that's one of the things that I'm incredibly grateful for, to have the opportunity to do this, is to see that happen with families. So all of this to give you a background on what's going on with the patient as they're interacting with their family. Now I'm going to transition into what this looks like, and the different phases of substance use intervention and treatment. So who is usually the first people to interact with a patient to try to intervene on their substance use? So who are the first people that jump in to intervene when they see a loved one is suffering with a substance use disorder? And clearly that is the family, right? It's always going to be the people closest to the person suffering with substance use disorder. Moms, dads, aunts, uncles, brothers and sisters, cousins. It may be chosen family. It could be really close friends, depending on what the individual has in their life, family-wise. But we see it time and time again that it's the family that usually intervenes first to try to step in and put a stop to the person with substance use disorders behavior. So this creates a conflicting perspective in the intervention phase. The family is baffled and deeply hurt by the behavior their dependent loved one displays in order to continue their use. This is something that they don't understand. It's you get a lot of, because of the confusing nature of it, you get a lot of, why don't you just stop? Or if you loved us, you would stop using. If you cared about your mom or your dad or your brother or whoever it is, you wouldn't keep doing this to yourself and to our family. And from an outside perspective, without an education on what addiction is, that logically makes sense, right? And this is why education becomes so important. And our next speaker, Samantha, is going to get into some of that. But the family is bringing in the perspective of being baffled and deeply hurt by their loved one's behavior. They can feel unloved, forgotten, disrespected, angered, saddened, and they transfer this into their communication. They are genuinely concerned for their loved one's well-being and can't understand why that person appears to disregard the family's well-being entirely. I'm going to want to give another example from my own experience. Is I was in college and still in active addiction, and my family drove up to see me and just called and said, "Hey, we want to take you out to dinner." And I didn't think much of it, and went to dinner with them, and they expressed all of this to me. They felt like I had forgotten them. They felt, angered and saddened and unloved because of the behavior that I continued to display. And they presented with a very sincere desire to be helpful, and came from a place of love and concern, but emotions were high because I was, engaging in using drugs that could kill me, at any point in time. And so again, like, logically, that makes sense. That's going to raise emotions for the family. And so, when we're working with families, and especially as that level of codependency begins to raise, you see higher and higher levels of emotionally charged attempts at trying to control the person with substance use disorders behavior. And this can create unhealthy communication patterns within itself. So not only, from the patient are you seeing dysfunctional communication and behavior, you can begin to see dysfunctional communication and behavior from the side of the family. So knowing that, and bringing it back to my own experience, when my family intervened on me like that, and they were asking me to go to treatment, I did not take that well. I did not. So from the conflicting perspective of the person with substance use disorder, here's a bit of a look at what it feels like during the intervention phase. When the family intervenes, the patient feels that their primary source of security, their drug of choice, is at risk of being taken from them. So we've established that for a complex number of reasons, the patient is using substances in order to alleviate distressing emotional and mental symptoms, or even physical symptoms in the case of chronic pain. So the drug of choice becomes the way that a patient is deriving their sense of security and well-being within the world. Now, the family comes in to intervene on that behavior because it's obviously concerning. You could overdose, you're going to jail, you've been to the hospital, you're failing out of school, whatever the consequences and external circumstances for that patient is that the family is seeing. They're seeing all of this, and again, red lights are flashing, and they want to come in and say, "Hey, this has to be stopped." But because of the hijacked reward system and the complex factors which contribute to addiction for each individual, the dependent person relies on their drug of choice to provide that sense of well-being. So this can cause the person with substance use disorder to feel attacked when family members intervene. It feels like the one thing I have in this world that is making me feel okay, that is providing me some relief from restlessness, irritability, and discontentment, from misery and depression, from anxiety, from a mental disorder, from coping with trauma, whatever it is. Now my family is coming in and is trying to pull that away from me. It can be experienced as an attack, as a personal attack. So in that situation, now supportive and loving family members can be experienced as obstacles to the dependent person's sense of security via continued use. I've seen this over and over again in working with families, and I experienced it in my own life. And that dinner with my family, I absolutely lashed out at them because I felt attacked. I said things that I didn't mean because I felt attacked, and it was the right thing to do. It doesn't mean that the family should not intervene, but to give a understanding of why the patient responds the way that they do, I feel like is important, so that we can have patience with the patient, so that the family can learn that it's not personal, that it's symptomology of their substance use disorder and the factors that contribute to it. This is crucial for an understanding for us as clinicians as we move, as I move into the next slide and kind of looking at behaviors that happen as a result of this. Is hey, we need a high level of patience to navigate this. Because the person with substance use disorder is feeling attacked, is feeling like they're one way that they're experiencing well-being in their life currently is about to be stripped away from them, and is going to try to fight for it. And so how does a person with substance use disorder try to fight for it? Comes out in all of these defense mechanisms or defense behaviors that we can see. And so as the patient is feeling the incoming dread of no longer being able to continue their use, you see denial. I don't actually have a problem. I could stop anytime that I want. Blaming the family, it's you guys that have the problem. If you weren't so controlling, then I wouldn't use. If you would just help me, and this is, by help me, it usually means continuing an enabling behavior of some type, then things would be okay. You can see anger outburst, becoming irritated and refusing to discuss the behavior that they're displaying. You can see distancing and isolating from family members, just completely cutting them off, not answering phone calls, not showing up for family events, and this can be a combination of protection of that behavior, shame, guilt, all of these factors. Internalized resentment, maybe it's, not anger outbursts, but simply internalization of a resentment towards the family. Deflecting with humor, making light of the severity of the substance use, making threats. If you do this, then I'll never talk to you again. If you intervene and say I have to go to treatment in order to live here, then I'm going to leave and I'll never talk to you again. And that would be a pretty mild example. But these are all defense mechanisms and behaviors that I have seen in working with patients that can be displayed because of this perspective and sense of being under attack. That my sense of emotional stability is at stake and is in jeopardy, and now these defense mechanisms and behaviors come out to try to protect it. Now, in the treatment process, I want to look at some specifics on how these behaviors can come out in a treatment setting due to this perspective. So the perspective of the person with substance use disorder does not automatically change because they enter a treatment program. I think it's very important that we understand that just walking through the door is not a solution in and of itself. So how the patient feels about their family intervening on them is not going to magically change the second that they show up for treatment. And so because of that, here's some behaviors that can be seen as as a means to try to protect the substance use, whether that's consciously or even unconsciously. Sometimes patients aren't even aware that this is why they're acting the way that they're acting. The first one, the most obvious one, would be trying to leave treatment AMA, right? Trying to leave treatment against medical advice, calling family members and saying, begging them to come pick them up, or saying, hey, if you don't come pick me up, I'm going to do this, getting back to some of those defense mechanisms. I'll never speak to you again, or I'll do something drastic. You have to get me out of here. This place is a prison, whatever the line is, people around trying to help, and the patient can feel attacked by not only the family trying to help, but in a treatment setting, the staff trying to help. Patients may say things like, my addiction isn't as bad as everyone's here. I don't need to be here, getting into that denial a little bit, saying, this was all a big mistake. I got this on my own. I don't need to be here. It could be misplaced anger, irritability towards staff members and peers in the treatment setting. It could be resistance or outbursts towards family for participation in the treatment process. This is family program attendance, family sessions, aftercare recommendations, boundary setting. Crucial that the family be involved in these aspects of treatment. It is, why as clinicians we go the extra mile in order to involve the family in the treatment process, is because it's been shown that treatment is more successful when you do involve the family system as a whole. With the patient feeling under attack because their entire way of life is now being, the rug has been pulled out from underneath them, the patient will often fight this family involvement, not wanting the family to participate in family program or family sessions, going against not wanting family participation in aftercare recommendations, not wanting boundary setting to take place. Patients may go to the lengths of even revoking consents of information for staff to speak with family members, or expressing a desire to re-enter the environment exactly as it was prior to entering treatment, despite family wishes and seeming to have an inability to acknowledge the high risk for relapse that this would cause. And so this conflict carries over into the treatment setting. So now, you've got the treatment staff involved, the family is involved, and the patient is, oftentimes, because of their perspective, fighting back against those that are trying to help them. And so as we're observing these behaviors with the patients, it's important to have an understanding of how to address this perspective that the patient has, this perspective and behaviors that the patient has. So as clinicians, what we want to be doing is focus on building rapport rather than fixing the client's perspective about the family system and family members. Attempting to immediately fix the client's perspective risk recreating unhealthy patterns of communication in the family system that can damage the therapeutic relationship. It also strengthens client resistance to the helping process. So if we come in and meet with a patient and they are angry with their family, they feel like their family has done a horrible disservice by intervening on their substance use and sending them to treatment, and there's a lot of resentment and a high emotional acuity around the relationship with the family and the patient's role in the family system. The last thing that we want to do is try to jump in immediately and try to fix that perspective. It's going to take the patient all the way back to that dysfunctional and unhealthy communication pattern of, why don't you just stop? Why don't you just stop? High level of emotion, and it will create conflict with the patient. The patient, again, taking it back to my very first slide, has normalized their perspective and behavior. They see this as the only way for them to experience life. And so if we jump in immediately and say, hey, you're wrong about, your family trying to intervene on you, you should think about it this way. Don't think about it that way. You're thinking about it wrong. And we try to go there too quickly and try to fix that situation immediately, we can destroy our ability to be helpful to that patient. We can destroy our therapeutic relationship with the patient and destroy our rapport with the patient because we're recreating that communication of conflict, high emotion, and placing the patient in a defensive position. Remember, they're already feeling attacked, regardless of whether it's true or not. The family, it does not mean that the family is attacking the patient. It just means, hey, this is how it's oftentimes perceived by the patient. And so instead of jumping in and immediately trying to say, hey, this is what your perspective should be, you should change it, what we can do is use active and empathetic listening skills, reflective listening, which is great for identifying underlying feelings, motivational interviewing. These are all skills that I wish I had more time to go into in depth. There's just no space. It's like the neurochemistry of addiction. They could be talks on their own. If you're not familiar with these, please look them up and do some research. These are skills that are incredibly helpful with working with someone through this perspective of feeling under attack. And also just simply understanding that, for a client who is in treatment, they may be involved in the 12-step process, that challenging perspectives and resentments towards family members, it occurs on the 4th step, not the 1st step. It takes some work to get to that point. And if someone is in a recovery program and is in a treatment environment, whether it's 12-step or otherwise, whatever they are using to work on themselves, they're going to be involved in an environment and a treatment program that is conducive to changing their perspectives. So what we want to be doing is exploring with the patient what their perspective is, asking them questions, and really listening to hear their point of view. Meanwhile, they're in a setting that is helping them with questioning their perspectives and challenging, maybe I'm not under attack here, but trying to get there too quickly can recreate that unhealthy communication pattern. And so in looking at family dynamics and family sessions, really want to, again, refrain from jumping in to immediately fix the perspective. What we want to do is focus on beginning to heal broken and unhealthy patterns of communication. The use of I statements, Samantha is going to get into some of that, but focusing on how I feel rather than the patient, pointing the finger at the family or the family pointing the finger at the patient, working with the system in order to create some healthy communications focused on the way that each individual feels within the system. Boundaries, initiated by both the client and the family. Boundaries, I think, are most of the time discussed from the perspective of the family setting boundaries with the patient and these types of family programs and stuff like that, seminars. But oftentimes the patient needs to be drawing boundaries with the family if there is extremely codependent behavior or a toxic environment at home, substance use, mental health, whatever it is, looking at assisting the patient and the family and communicating boundaries in a way that can at least begin the process of healing broken patterns of communication that Lucas talked about. And then also making strong recommendations and fostering motivation for family involvement in the treatment process, attending family programming, accessing educational information on addiction, family support groups, obtaining individual counseling if needed. All of these things help to bring those two conflicting perspectives of the family perspective and the patient perspective it's through these things that the conflict, at least the volume, can be turned down some on it. And Samantha's going to get into some of those programs as well. But really just, focusing on healthy communication as clinicians, especially in an inpatient treatment setting where someone is, maybe 7 days removed from their drug of choice, and we're in a family session. We're not going to fix the entire perspective all at one time. It's patience and understanding, where do I need to start? Well, healthy communication is a great place to start. Through healthy communication, over time, changes in perspective can occur, especially within a conducive recovery environment, a treatment environment, making sure that the patient is in the appropriate level of care for what their needs are, really helps to facilitate that perspective change, and can build reunification and healing of the family system. And so to close, I want to end with that, an encouragement to trust the process. Recovery from substance use disorder takes time and work for the person in recovery. Also, disclaimer, regressions in perspective and behavior can occur without relapsing back into direct substance use. I see this a good bit. You do not necessarily have to relapse back into using in order to have perspective and behavior, those defense mechanisms that we discuss, reoccur or come back out even if they seem to be resolved for a period of time. So having the patients to use those active listening and empathetic listening skills, using motivational interviewing with the patients as they're going through this process, becomes imperative throughout the ups and downs of especially early recovery and getting adjusted to a life without substance use. And from the family side, healing from a loved one's substance use disorder takes time and work for each family member. And healing the dynamics takes time and work on both the individual and family's part for the family unit as a whole. And so with that, I want to say thank you guys for being here, and thank you for allowing me to speak with you all. This transitions into exactly what Samantha is going to be talking to you guys about. She's going to go more in depth on the healing process. So I'm going to transition over to her, and as Lucas said, get my technical difficulties taken care of here. But thank you guys again, and I hope you all have a great day.
Hey, so my internet went out, but it just came back. So I'm sorry if I missed the crossover. Let me get my screen shared. I am Samantha. I work, I'm here at the Mobile office, part of Bradford, and I have been, I've been working or leading the family support group here for about 3 years. And I've also helped with education classes since I've worked at Bradford, and various groups and things like that. I'm also in private practice. So I see, a lot of patients with substance abuse history, and work a lot with that as well. I also have grown up with a lot of addiction in my family. So this is, a lot of the things that I'm going to talk about today are things that I kind of wish I knew years ago. So it's so helpful for families. So Lucas talked about family systems and how families are affected by addiction. Turner kind of gave us that perspective from the view of someone in recovery. And I'm going to talk about how to help the family system as a whole heal. What we know is that addiction is a family disease. So how can we help the whole family heal? First of all, education is so important. And I think Turner kind of talked about that a little bit. So we're going to talk about education and why it's important and what are some of the concepts and aspects that are the most important to understand. I'm also going to share some outside support and resources, different groups and things that are available for family members. And then how to heal relationships after they've been damaged. Maybe not even heal them, but create them. A lot of families don't have good relationships to begin with. So how to create and heal those relationships. And finally, I'm going to get into some interventions that we can actually use, whether it's an individual or group therapy. So education, neuroscience, and development and progression of addiction could take an entire webinar in and of itself. But what I want to talk about is why it's so important for family to understand this, and not just family, but also our patients, people who are struggling with addiction, to understand how these things happen. For the family to understand the neuroscience and how it's progressed through the years is how they can create empathy for their loved ones. There's also the loss of control when you're in a family of people struggling with addiction. There's that loss of control. And so understanding and learning is one way to take some of that control back for family members. And that's one of the ways that I kind of present the family group to people is, it's for you. It's for you to take control back. And our family group is only for loved ones, or it used to be called like concerned persons group. So concerned persons group, or, family support group. And then triggers are also important. A lot of times family members have difficulty understanding why certain things are triggers or how they develop. And it can create a lot of resentment of why they can't go certain places anymore or do certain things anymore. And understanding how the brain works and triggers cravings to use is really important for the family to understand and help them support their family in their treatment goals. And then dual diagnosis, that's also already been talked about a little bit. Turner talked about that. But a lot of times substances are used to self-medicate. So whether the co-occurring mental disorders come first or after, the substance abuse has to be treated first. And not, you don't finish treatment, you don't finish substance abuse treatment and then move on to the other things. It all kind of occurs together, but sobriety has to be obtained, and then the other things can be treated. But it's also important for us to remember that addiction and treatment can be considered a trauma in and of itself. The changes that happen in the brain, and sometimes the stigma that surrounds addiction and treatment, and then even just going into treatment can be considered a trauma. You're leaving your family, you're leaving your friends, you're leaving everything that you know and learning a whole new way of life. That can be traumatic for people. And so we need to keep that in mind when we're treating. So just like addiction is a process, so is recovery. It does not happen overnight. A lot of family members come into group and they have trouble understanding that things are not going to get better straight away as soon as their loved one comes out of treatment. They kind of think that the work is over. So the person is sober now, so everything's going to be better and we can just move on. But there's a lot more to recovery than just staying sober. But a couple of the aspects that I feel like are most important for family members to understand is post-acute withdrawal symptoms, which we call PAWS. Those acute withdrawal symptoms that happen right after someone, um, obtains sobriety, those are all the detox symptoms that we kind of know about, and that's what they treat in inpatient. But these pause symptoms can last for months or weeks or months, sometimes even up to a year or more for some patients, depending on how long they've used, what substances they used, and different things like that. But the symptoms that accompany pause can be difficulty with cognitive tasks, so learning, problem solving, memory recall, irritability, anxiety, panic, depressed mood, obsessive compulsive behaviors, craving substances, difficulty maintaining social relationships, pessimism, apathy, um, disturbances in sleep patterns, increased sensitivity to stress. So just a whole range of symptoms. And if you notice, those symptoms all can look like using symptoms. So that people experience in active addiction. So something that happens a lot in family group is, and with family members, is they come in and they think, things are going great. My loved one is still sober, or they say they're still sober, and they're going to meetings and they're doing all the things that I think they're supposed to be doing. But now they're experiencing these symptoms and I feel like I'm on a roller coaster. So I hear that a lot, especially from spouses. And that can, create paranoia in the loved ones, maybe like accusatory type of situations and things like that. And so understanding pause is a really big thing for family members. And also for patients that are in recovery, sometimes they don't know what's happening to them. And what's frustrating about pause is they occur kind of in cycles. So maybe a couple weeks after reaching sobriety, and then 30 days, 60 days, 90 days. And it's not for everyone and it's not always on the dot, but it does tend to occur that way. So that is very frustrating. But when those things occur, the good thing about that, kind of the silver lining, is that it shows changes in the brain. And so it just is showing that the brain is healing. So it takes some time, but it'll get there. So that's post-acute withdrawal symptoms. The next thing is medication-assisted treatment, which is another concept that a lot of people have confusion about. I'm not going to get into it too much, but there is a lot of controversy surrounding MAT. So some examples like methadone, naltrexone, Vivitrol, those are all MAT medications that we use to treat opioid disorders. And the controversy kind of stems from a place of concern that you're replacing one thing for another. However, in the current atmosphere where so many drugs are laced with fentanyl and we don't know what it looks like or which ones it could be, these drugs can be so helpful, or these medications can be so helpful to prevent relapse, which today can be fatal. So that's why we sometimes, integrate MAT. Campril is another one that's helpful for alcohol addiction. These medications are also really helpful with those pause symptoms. So to kind of help that roller coaster stabilize a little bit. And it also helps keep people in recovery motivated for treatment. So that is, one of the reasons why we utilize MAT. So next, going into relationships, like I said, sometimes there were no healthy relationships to begin with. So we're kind of teaching how to have healthy relationships or healing, what was already there. So first of all, and I'm going to get deeper into boundaries and communication in just a few minutes, but boundaries are so important in recovery, but also these concepts are so important for all of our patients, whether they're dealing with addiction or not. So, or even, whether it's friendships or work relationships or anything like that, these, relationship goals are important to understand. I've also, I've had people in family group come, and even when their loved one that they started coming to group, that was their motivation for coming to group, even if that person is no longer in their life, a lot of people will still continue to come because they get so much out of it, whether it has to do with addiction or not. So boundaries are important because that's how we take care of ourselves and create safety for ourselves. Communication, of course, we know communication is key for any relationship. And then codependency, which Lucas already talked a lot about codependency. But what's funny about codependency is I often have people come to family group, and every week what we do is everyone kind of checks in, and then we read from Melody Beatty's book, The Language of Letting Go, which is just a short meditation for the day. And sometimes I hear concern from people like, codependency is not my problem. I don't know if I need to come to family group, if this is what we talk about. And generally, those are the people who keep coming back and get a lot out of the codependency talks. Because we discuss the meditation every week. So codependency tends to run deep, whether people realize it or not. And also what I wanted to point this out, a lot of people who don't think that they grew up in a household with an addict, maybe they grew up in a sober household and they develop a lot of these tendencies. They don't understand why. And so when I'm doing intakes and assessments in in private practice, I also ask about how their parents grew up. So if their parents grew up in an alcoholic household, some of these characteristics will continue on. And so I've even seen that in my life. My dad's been sober for 41 years. Yay. So that's before I was born a few years. And so, but I noticed that he still had some of those characteristics because he grew up in an alcoholic household. And then, even in recovery, all the healing that he did, there's still some of those characteristics there. So you're able to see that. So just because a household might be sober, there still might be some addiction qualities there. So support and resources for family members. First of all, self-care. One of those big things about codependency is feeling selfish for taking care of yourself, which of course is not true. So teaching our clients to take care of themselves is one way to kind of counteract that codependency trait. So positive reinforcement skills is one way to kind of work on self-care, and that this is kind of a DBT skill, but it basically helps people learn to find positive things with their time. And this is something that's helpful for family and also for people in recovery. So it kind of helps to combat that self-pity, like why me, why my family, type of thing. So finding short-term positive experiences, finding long-term positive experiences, and then, maybe helping your client list positive activities that they might enjoy doing for themselves. And then the second part of that skill is getting into the habit of giving other people positive reinforcement, which just kind of helps us, or helps our patients become positive overall. Maintaining boundaries, I didn't list that on there, but that is a big part of self-care, is maintaining boundaries. That's how we take care of ourselves, not anyone else, but just ourselves. Individual therapy, again, there might be wounds and trauma from before addiction, but there's also so many different things that can occur within addiction itself. So whether it's for the family or the person in recovery, individual therapy can help that. And then there's also recovery programs that are built just for family members. And a lot of people don't realize this, but there's Al-Anon, Nar-Anon, Codependence Anonymous, Celebrate Recovery. There's also Alateen for teenagers. But Bob Smith and Bill Wilson were the founders of AA. So pretty much everyone knows what AA is, Alcoholics Anonymous. And then Narcotics Anonymous and all those other programs kind of came from that. But when Bob and Bill became sober and kind of started their journey of the 12-step program and bringing the message to the masses, what their wives found is that they still weren't happy. And Lois Wilson was Bill Wilson's wife. And so she kind of, they believed that their entire problem was the person with addiction. So once they got sober, then life would be perfect, right? And that's kind of the mindset that a lot of family has. And that's not true. And so they kind of created Al-Anon, or founded Al-Anon, to be an offshoot of AA. And so this is built just for family members. So it's the exact same 12 steps as AA, but from a different perspective. So like step 1 for AA is we admitted we were powerless over alcohol and that our lives had become unmanageable. It's the exact same wording for Al-Anon, but the steps are built differently. So as a family member, I too am powerless over alcohol. I can pour out bottles or mark lines on bottles or throw things, flush things down the toilet or whatever. That power or control is a whole illusion. And so I have to admit that I'm powerless over alcohol, and that's how Al-Anon works. So all these different programs, if I'm a family member of an alcoholic, I can go to Al-Anon, I can get my own sponsor even, I can work the 12 steps. And so I always recommend these programs to people who come into the family support group. And I have several people who do both. They go to Al-Anon and family support group because it's a little bit different. And Celebrate Recovery is one that is more faith-based, and it is not only for family members, but also people in recovery. So they can actually go together. So those are just some various resources for family that are helpful. Detachment is an Al-Anon term. So this is something that kind of came out of Al-Anon. It was noticed that people with addiction were often overprotected. So in other words, that's those enabling type of behaviors where you're overprotecting someone and they're unable to learn from their mistakes. So detachment with love means caring enough about others to allow them to learn from their mistakes. It also means being responsible for our own welfare and making decisions without ulterior motives, such as the desire to control others. So a lot of these concepts have to do with our motive. So our motive should never be to control someone or manipulate them into stopping their use as family members. That should not be the goal. It should be to protect ourselves, or the family members should be protecting themselves. So, and a couple of examples of this would be if there was an adult child who had stolen from the home before to get, their substance of choice or whatever, to tell them, that they're not allowed in the home anymore. And so working with family members, this is extremely hard for parents to do, but it creates so much more peace in the relationship, and it helps them protect their relationship with their child. So they might meet them outside of the home instead of letting them into the home. So again, it's not a manipulation tactic, stop using or I won't let you into the house. But as long as you're using, I'm going to meet you outside of the home, like that. Or even like if it's with the spouse or other family member, if they're not going to work and the boss is calling or whatever, not covering for them. So again, it's not manipulation. If you don't stop, I'm going to tell on you type of thing. But if this happens, this is what I'm going to do. And then the 3 C's, this is another Al-Anon term, and it's a really basic concept, but it's kind of a building block for family members. And when I'll do kind of random assessments in family group, like what have you found most helpful, and what has been the most helpful thing for you to learn. And this commonly comes up. So learning, I didn't cause it, I can't control it, and I can't cure it. I didn't cause it. That is one of the kind of guilt statements that I hear a lot from parents. And trying to control it, that's a responsibility statement I hear a lot from spouses or significant others. And then trying to cure it, there's treatment for addiction. And that's where education comes into play too. But this is really helpful for a lot of family members. And then boundaries. So moving on to boundaries, why are they important? How do we implement them, and how do we enforce them? So boundaries are important because they teach everyone how to treat you. So phrase of we teach people how to treat us, that's kind of where boundaries are. They give everyone a clear lane. So especially in a family that's healing from addiction, it keeps everybody in their own lane. So just like going back to the 3 C's, just like we can't control someone's use or their addiction, we also cannot control their recovery. And that's important for family members to understand as well. And then how do we implement boundaries? A good thing to do here is a values assessment for clients, because our boundaries should reflect our values. And this part of boundaries is what trips people up a lot, because it's not black and white for every family, because every family is different. Everyone has different values. So it can be difficult, but kind of a universal value is like truthfulness, like lying is not good. So if that's your value, if you value truthfulness and you're lying to the boss, or you're lying to friends or family, then that's crossing a boundary. So that might be a boundary that you put into place of, I'm not going to lie anymore, or a family member would put into place of, I'm not going to lie anymore of these things. So it's not telling the other person what to do, it's what am I going to do or not do. And how to enforce boundaries. This is actually easier than what it sounds like, because you're not controlling the other part. You're not enforcing a boundary on someone else. you're enforcing your own boundary. Boundaries protect whoever set them. So whoever set the boundary, that's who it's going to protect. So communicating what your boundaries are and letting people know, because if you suddenly, if we're talking to our family or patients about setting boundaries, they need to communicate to the family, like, this is what I'm going to start doing from now on. So it needs to be clear, concise. It needs to be something that you can actually enforce. So don't say you're going to do something if you're not going to. So a boundary is defined, it's a limit or space between you and the other person. So it's clear where I begin and the other person ends. The purpose of setting a healthy boundary is to protect and take good care of you. Boundaries create safety, and in a family that has dealt with addiction, there has not always been a lot of safety. And so boundaries can help heal that wound of not feeling safe. There's different types of boundaries. So physical boundaries, that's your physical space and personal touch. So if I have my bubble or my hula hoop, that's my physical boundaries. If someone invades my personal space or anything like that, that's a physical boundary. Intellectual boundaries are thoughts and ideas. So if someone belittles or dismisses someone's ideas, so, well, that's stupid, why did you think that, or why that's a dumb idea, that's crossing a boundary. And then emotional boundaries, these of course refer to feelings, and again, that invalidation for your emotions can cross that emotional boundary. So if someone is disrespectful, you could say, I can't talk to you until, or you're being disrespectful, so I feel like I need to hang up the phone or something like that. So you're not telling them to do something, you're going to hang up the phone or whatever it is, or leave the space. Material boundaries, so money, possessions, can be violated when someone steals or pressures them to give more than they're comfortable, which happens a lot. And then time boundaries. So how much time spent or how to spend time can be violated by others demanding too much time, using time ineffectively, or saying they're going to be somewhere and then not being there. So that can cross a time boundary. So rigid boundaries are those inflexible boundaries used to keep others at a distance. When people think of boundaries, when I hear people say, oh, I have really good boundaries, they tend to be talking about these types of boundaries. So they generally have like very inflexible boundaries. They're avoiding intimacy, struggle to ask for help, very few close relationships, protective of personal information. They may appear detached, which is not referring back to the detaching with love, but just detached, so being closed off. They tend to be afraid of rejection. All of this goes back to difficulty trusting, being afraid of being vulnerable. So someone who's been let down a lot in a family with addiction, they might go to the extreme and create these rigid, closed off boundaries. On the other hand, we have porous boundaries. So when people think of codependency, this is kind of what they tend to think about. So these are very loose, flexible boundaries where someone does not have a personal identity. And this goes back to Lucas kind of talking about Benifer, So there's no personal identity. They're intertwined with others. So this is the person who overshares personal information, struggles to say no, over involved in other people's problems, dependent on other people's opinions, likely to accept abuse or neglect because otherwise people might leave, and then fear of rejection or not being liked. So this is the people pleasing characteristics. somewhere in the middle are healthy boundaries. So these people that have healthy boundaries, and what we want to teach our clients, they make decisions based on their current needs and abilities. And notice it says current because sometimes our needs and abilities change, and that's okay. So teaching them that it's okay if your needs change and there's no guilt there. They're able to have intimate relationships. They value their own opinion. They understand their values and won't compromise them. They share personal information in a healthy way. So they're not oversharing or undersharing, and they're sharing this information in appropriate settings as well. Knows and can communicate wants and needs, accepts when others say no, and they're able to ask for help in a healthy manner. So that's healthy boundaries. So going into examples of boundaries in early recovery that family members might want to set into place. So we want them to complete treatment successfully. So that means following the treatment plan that the treatment team has prepared for them. So checking off those boxes, including family and family sessions if appropriate. And that goes back to communicating and understanding, asking if they want you involved or not. Following through with aftercare plans, not using substances, including less harmful ones. So examples of less harmful ones of what people will say are like Delta 8, even marijuana, people view as a less harmful one. What's the other one? Kratom is one that people tend to kind of fall back on. So not allowing those. Being open to more accountability, being transparent with action plans and emotions, actively working a recovery program, whether it's AA, NA, Smart Recovery, Celebrate Recovery, whatever recovery program, but actively working it. And then seeking consultation if lapse or relapse occurs. There's relapse sometimes can be a part of recovery. And so if that happens, it's getting back up and asking for help. So going into communication, I statements, which I'm going to talk more about on the next slide, but I statements are so helpful because they can't be argued with. So if I feel a certain way, you can argue with me, but you can't really get defensive about how I feel. So that's why I statements are so helpful. So we encourage patients and their families to use these statements when they're talking to each other. Generalizing is basically stereotyping. So generalizing behavior, we don't want to do that when we're talking to each other. Hijacking. So we want communication to be a back and forth. So think about throwing a ball back and forth. That's how communication should be. So in treatment, patients are encouraged to say like no hijacking if they feel like someone is taking over the conversation, and that's kind of a common group thing that we do. But you can also do that in family conversations as well. Let the other person know that you feel like the conversation is getting hijacked. And then no rescuing. So rescuing, that's an enabling behavior, doing something for someone that they could be doing for themselves. So if they can't find the words, finding them for them, that's rescuing them in the conversation. Cheeseburger words, we actually talked about that this week. So that's where you're saying, well, how was something? And they use a one word like fine or good. So it's words that you would use to describe a cheeseburger. So how was your cheeseburger? It's fine. So we don't want to use those words. We want to be honest about how we're actually feeling. We want the family members and the person in recovery to learn to be honest about how they're feeling. The family generally feels like they're walking on eggshells because they did that all during active addiction, and then going into recovery. A common question that family members will ask in family group is, how do I ask about this? Or is it okay for me to ask them this? Of course it's okay to ask your family member if they're doing well. You would ask anyone else if they're doing well. So kind of teaching them not to walk on eggshells and getting comfortable with how they're feeling and verbalizing how they're feeling. And then body language, so paying attention to other people's body language, but also your own. So if you're appearing closed off, then your family is not going to feel comfortable to talk to you. So body language is definitely part of communication. So I statements feel very, very cheesy when you first start using them. But if you can use it enough for it to feel authentic, they work so well. So I feel blank. And so not I feel that, but I feel a feeling. So I feel sad or insecure or angry or happy. So you can use this as a positive reinforcement statement as well, not just negative. So I feel happy when this happens. And then in the when blank, so I feel sad when, it doesn't always have to be I feel sad when you do this or don't do this. It can also be I feel sad when I cook dinner and it ends up going to waste because I didn't know you weren't going to be home on time. So it doesn't necessarily have to be I feel sad when you don't call me on time. So you can put a situation there instead of what the other person is doing, if that makes sense. So, and then you're going to continue that with what I would like is for you to call and let me know if you're going to be late. So that's those I statements. And again, this is powerful because no one can tell me I don't feel sad or whatever. So I statements are a big, big help in family communication. So continuing with communication, these next couple of slides, I have a few acronym slides, but they can be helpful depending on what your client is struggling with. So this one and the next one are kind of like the spirit that you should have when you're communicating. So it's kind of a way of being when communicating. So fast, so being fair, not taking advantage of others or the situation. Apologizing for what you need is not allowed. So if this is something that I need, I shouldn't apologize for that. Sticking to your values again, and then being truthful and not exaggerating. So that's where the whole you always do this or you always do that, those are generally exaggerations. My daughter tried to fight me on that last night because she says her sister always does this or that, and so we had a whole talk on that. But this is how to be true to yourself when having conversations and communicating. The next one is give. So being gentle, and what I always say is say what you mean and mean what you say without being mean. So you don't have to be mean, you can be gentle in your conversation. Interest, so active listening, teaching our clients how to actively listen to their family members, validate their feelings, and then go easy. So you don't have to be too serious, like have an easy manner about you. And again, these will kind of go with who needs it the most. This next one, Dear Man, is a way to get your point across without being accusatory or losing your temper. So a lot of times, our patients get frustrated in communicating. And so this can be helpful with that. So I'll give an example. So describe the situation using just the facts. So I'm going with the whole not calling home dinner situation again. So when you come home late, or you came home late, and don't call me to let me know. So that's just the facts. You didn't call to let me know you were coming home late. And then expressing your feelings using the I statement. So I feel scared that, something happened or whatever, or I feel disrespected, or I feel upset that I had to throw the food away or whatever. Assert your wishes or needs. So in the future, I would appreciate that you call and let me know, or text me, or whatever, or we make plans. Reinforce positive behavior, set expectations and boundaries if your needs aren't met. So you're kind of explaining why that thing is important to you. So the food could be cold. We might have to throw it away. I could have cooked it, it was good food. I could have cooked it on a night that we were all together, or, whatever that is. And then mindfulness. So staying aware of your objective. So if the other person starts giving excuses, getting defensive, rationalizing, this is, just stay mindful that that is happening, and stay on your track, regardless of what is happening on their end. And then appearing confident, eye contact, speak clearly, sit up straight, and then negotiate. So collaborate for solutions. Compromise is important in relationships. So how can we resolve this together? What are your ideas to make sure this doesn't happen again? So it's not a controlling type of situation, it's collaborating. And then stop. So stop, take a deep breath, observe what's happening, pull back, and use perspective. And this would be good to use if you're at the mindfulness part here, and the other person, if you are being mindful that the other person is getting defensive or whatnot, then you would do this. So stop, take a deep breath, observe, pull back, use perspective. Okay, they're getting defensive. Maybe I am raising my voice. Maybe I am whatever. So use that perspective there. And then active listening skills. We do this all the time, but we want to teach clients to do this. So asking open-ended questions. So in recovery, like I said, a lot of family walk on eggshells. They're afraid to ask questions. So instead of saying, well, how was your meeting tonight? Fine. So what did you learn in your meeting tonight? So asking those open-ended questions like that. Well, what did you learn, or what did you get out of this? Or did you learn anything that would be useful for me at your meeting tonight? So asking those open-ended questions, validating their experience, reflecting back, and then staying mindful. Validation. We say that a lot, like validate their experience. So this is understanding where the other person is coming from, even if we disagree with what they say or do. This is hard for family a lot of times, especially when they don't understand addiction or recovery and everything that goes into it. But teaching them how to validate and what that means. And then there's different levels of validation. So paying attention, no multitasking. So, like personally, if I'm talking like to my husband or anyone in my family, really, even my kids, and I'm talking and expecting them to listen, and a phone comes out or whatever it is, I can't necessarily, with my kids I can, but not with my husband, well, I guess I could, but instead of saying, put your phone up or whatever, I stop talking. And that's a boundary, for me. Again, setting a boundary is, what am I going to do? So I stop talking until I get the attention. So on the other side of that, that's how you can handle it. But teaching them not to multitask and to pay attention, to situations when someone's talking to you, reflect back, repeat what you've heard, be sensitive to the unspoken. So body language, different things like that, understand, making sense of another person's feelings. So teaching them to say, what I understand is this, or can you help me make sense of this? I don't understand. So just asking, acknowledging the validity in response to current facts. So even if you don't understand all of it, acknowledge the part, what is valid or what you understand. And then, of course, showing equality, treating the other person as an equal in the conversation. And so this is a diagram. So I'm kind of moving into some different interventions or different exercises that we can do with clients. And this is a trust diagram, because obviously trust is a huge part of addiction or distrust. And so kind of getting that trust back. Family members, when I talk to them, they become frustrated because they don't trust their family member yet. And so they have a hard time understanding, like, why don't they understand that I can't trust them yet? And then on the flip side, the person in recovery is like, why don't they trust me? Like, I've done everything that I'm supposed to do. And so this is why individual healing is so important. So using this diagram, you could do this in session. You could do it on a whiteboard, on a sheet of paper. You could make this into a worksheet or whatever. You could do this in a group setting, couples therapy, family therapy, anything. So part of building trust is being reliable. So the person does what they say they're going to do when they say they're going to do it. Being open to feedback, so that willingness to give and receive feedback and share information. Radical acceptance and non-judgment, even when we don't accept their behavior. And then being congruent, you walk your walk, talk your talk, and practice what you preach. And so those are kind of the building blocks of trust. So what you would do is kind of have the person put, what comes most easy to me, what maybe needs more energy. So this is just some examples. So as far as being reliable, maybe the person in recovery might say, I came to the dance recital when I said I would. The family might say, I did the family group like I said I would. So those are just examples of what reliable means. So that might be something that comes easy. Being open to feedback. This is typically like kind of a hard thing for family members. So the person in recovery might say, I became frustrated when you asked me about meetings. That does happen a lot. The family might say, I became frustrated when you gave me suggestions on how to communicate better. So that might be something they need more energy in. So those are just some examples of how you would use this diagram in treatment. And getting them to kind of think about that. And you could also let the family member fill one out, and then let the person in recovery fill one out, and then kind of switch them and see what the other person thinks that they need to work on more. So that could be something that's helpful as well. Writing a letter to the addiction. This is something that is helpful for people in recovery and also the family members. And again, this can be done in group setting or individual. Couples, family, you could have them write their letter to the addiction and then read each other's. Or if you're using this in a group setting, you could have the person who wrote the letter, they would stand and another person would read the letter to them. And it's just kind of processing what was said. Another way to do this intervention is writing the letter as the addiction. So, for example, it would say, hi, I'm your opiate addiction. This is what I came to do, or something similar to that, just to process through that. Unconditional love exercise is something that is good in group or individual as well, but especially as a group exercise, even as a warm-up exercise, this is good. What you would do is the person the client who is doing the exercise would stand behind an empty chair, or if it's in a group setting, you could have someone sit in the empty chair and they would introduce. So if I'm the client, I'm standing behind the empty chair and I'm introducing myself as someone who loves me unconditionally. So this person, I would say like Samantha, is strong, organized, strong-willed, or whatever like that. And that can be a helpful warm-up exercise for people. And then finally, this is the last one. And I actually love this one. But what happens with a lot of people in addiction and then also in the family is they get stuck in these bottom boxes down here. Introjection is internalizing shame, hatred, resentment, bitterness, those types of things. So introjection, that's internal. Projection is blaming and lashing out at others, externalizing pain. Codependency, we learned about already. So unhealthy relationships without boundaries, that's part of it. And then addiction. And so this exercise you can do in a group setting or individual. This is helpful with families. Or if you're doing couples therapy, let them figure out which of these boxes they spend the most time in. And kind of process that. And sometimes you'll move around in this box or have one foot in two. But what's important is getting through this pain box. So the pain box is whether it's trauma, emotions, suffering, like pain. So stepping into that box and figuring out what's in there and feeling through that, and then stepping into recovery. So again, this could be a worksheet, or this could be actual, like you could put tape down on the floor to make the boxes and have the people actually stand in it. So this is a really good exercise to use with people. But to get through the pain box, that's where therapy comes into play. So that's what we want people to do is do the therapy, do the work, and then get into recovery. And this visualization is really helpful for getting people there. So holiday considerations, going into the holidays. Again, expectations for the holiday. There's a lot of parties, there's a lot of get-togethers. Having people communicate what are their expectations, because no one is a mind reader. What do you expect from your loved one? What do they expect from you? And then working through that together, the collaboration, talking about what are your triggers, like what do I need to know going into this holiday? And then figuring out what you're going to do together, and all that family tension, whether it's judgment, stigma, why are you going to these meetings? Why is this, so-and-so didn't have to go to this many meetings or whatever. So all those different types of things, that's where boundaries come into play. So reiterating all those healthy boundaries to get through some of that family tension. So there's a lot that could be said about holidays. But communication and boundaries are the big things. So that is what I have. So I think Austin is going to come back in now.
Wow. Thank you guys so much for these extremely informative presentations. That was great. Thank you all so much. So that was a great discussion. And with the time remaining, we'd love to get your thoughts on questions. So if you're in the audience and you have any questions, please feel free to put them in the Q&A. Our first question is actually directed to Lucas. And Lucas, that question is, did Bowen find that those who had supportive, loving, healthy family systems had less PTSD?
Yeah, I think that's a really great question. Now, the idea of supportive, loving family systems, I think that so in this case, that's not really what the issue was and what Bowen was focusing on. What he was really focused on was the levels of differentiation within the family members. So if someone left the theater of war and went home to a family that was that undifferentiated family ego mass that we were talking about, where everybody's kind of sharing a sense of self, and there's not a whole lot of internal locus of control in the members of the family, then that person was going to more likely to experience the long-term negative effects of the traumas that they experienced while in war. Well, if they had gone home to a family with high levels of differentiation, where each person within the family is fairly well defined and can separate their intellect and their emotions, that person is likely to experience fewer negative consequences, just because the family wouldn't be as focused on the trauma, right? They can move forward. That person likely experiences higher levels of differentiation and has really good coping mechanisms for dealing with high levels of stress from outside the family and the anxieties that go on within the family.
Gotcha. Okay. Thank you so much, Lucas. And thanks for that presentation again. I don't think that we've got any more questions in the Q&A that I have received. Oh, one might be incoming. Y'all have been a great, really responsive audience. We really appreciate the feedback and the encouragement. Let's see. We've got one question here. Deborah wants to know, how do you address an adult daughter with an obvious problem who calls and drinks, and you can tell by her conversation changing? And as she becomes disinhibited, she tells me that her hubby and daughter think she drinks too much, but all she had is 1 or 2 glasses of wine. She's long distance and our relationship has been strained for years. Her teenage daughter is calling her out. Do any of our panelists want to take that?
Sure, I don't mind hopping in on that one. It's a difficult situation for sure, with it being long distance. What my recommendation would be to see if it would be possible to discuss her drinking with the husband or even the teenage daughter, since you're not there and witnessing what's going on, to see if you can get some more insight into what the drinking is looking like, and then move forward from there with a full spectrum of information on exactly what's going on. Because, like you mentioned, with you only, discussing this briefly with her on the phone and being long distance, it's going to be difficult to gain a real insight into the severity of the situation and what's going on. And it can be helpful in those instances to triangulate some information to get a full picture. And then once you have a full picture, and then game planning can begin with the family that's on the ground, as far as the husband and the daughter, as far as, hey, do we need to set some type of intervention up? Is treatment needed? That sort of stuff. But I would first and foremost reach out to see if more information can be found through the family members that are living with your daughter. And just want to say, I know that's incredibly difficult and must make it harder to also be far away and not there. So thoughts and prayers with you, and hope you get the information that you're seeking.
Hey, Turner, since we've got you up there, thanks for answering that. Can you share any books or any other resources that you utilize?
Yeah, so for families, I would really recommend digging into the Alcoholics Anonymous text, the referred to as the Big Book. You could Google that. There's an entire chapter called The Family Afterward in that book, which is really, really good information for families. That's what the primary text for the Al-Anon family groups as well. I would definitely recommend looking into that chapter specifically, as it addresses dealing with a loved one who is actively drinking and addiction.
Okay, thanks so much. Samantha or Lucas, did either of y'all want to chime in on any input on books or other resources that you all utilize?
Yeah, sure. If anybody's really interested in getting into family systems theory, there's a book called One Family Story by Dr. Michael Kerr, who was a student and a collaborator with Bowen, and that's an excellent resource, very much worth checking out.
Awesome, thanks. Samantha?
Yeah, we mentioned Melody Beatty a couple of times, so anything by her. So there's the Language of Letting Go, which is kind of just a like a meditation type book, but also Codependent No More, and there's workbook to go along with that. And then Beyond Codependency, she writes. And then any of the Al-Anon literature. So the 12 Steps of Al-Anon, that would be a good book to recommend.
Absolutely. And can you reiterate the support groups that you went over? I think that some people just wanted a refresher on those. Some people missed them.
Yeah, for family members, there's Al-Anon, and then there's Nar-Anon. Celebrate Recovery is also for family members. Codependence Anonymous would be really good for families. So any of those groups. And then Bradford has the family support group that meets weekly. So also, as far as boundaries, Cloud and Townsend write a lot of books on boundaries. So those are good. Those are very useful to have too.
Awesome. Okay. Well, thank you so much. Thanks, Samantha. And thank you all again out there for joining our webinar today. Again, thanks for your participation. We really appreciate it. I'm going to put my name, phone number, and email in the chat. And if you all have any questions about Bradford or want to know any more, please reach out to me and I will get you hooked up with the person in your area who can tell you more about Bradford. If you're in the Memphis area, I can certainly bring you lunch, bring your office lunch, share with you more about the programs that we have here. I know that Samantha was just talking about the family program on our website. You can find out more about that. It is Bradford's approach to addiction as a family disease is pretty incredible. And we work closely with families, but we have so many programs under the Bradford umbrella. We've got every level of care you can imagine for substance use disorder. And I would love the opportunity to tell you more about it. So again, I'm sending this out right now. Please feel free to text, call, or email me, and I will get you connected with the rep in your area. If you're not in the Southeast, then I would certainly be happy to set up a Zoom chat with you. And we really appreciate you being here at our last event of the year, at our last webinar of the year. And this will conclude today's session. Please remember to be on the lookout for post-session email with materials from today's presentation and the survey link to complete the evaluation for your CEU certificate. So again, for those, I know that there was some questions about the CEU, and whether or not we would have access to today's presentation, but there will be a recording of today's presentation as well as the other materials that we've discussed. So just be on the lookout for that email. Make sure to fill out that survey in order to get your continuing education credits. We hope that you can join us for future topics next year, and we hope that you have a wonderful day, a wonderful weekend, and a great holiday season. We'll see you next year.